this session. A few introductions. I'm not going to introduce everyone. The CST team, please introduce yourself while you're presenting. I am Puneet Aluwalia, the CST lead from Renal, and we have this SWAT team members listed on this slide. Pretty much the same SWAT members for all the renal clinics. Okay. The purpose of this design session is to review and confirm the Nocturnal build options that would be used to meet the clinic's identified requirements in preparation for validation session that would be in mid of May. This is our guiding principle. Our focus is on enterprise design, and we would support our 3 HOs with establishment of common clinical and process standards and workflows, order sets, clinical guidelines, integrated plans of care, and the electronic health records. The must-haves that we would include when we are designing the system for you guys is safety, regulatory, financial, and the content that would be added in Cerner. This is a slide which has the glossary items, and I know it's been a while since we had our first requirement gathering session, so I'm just going to quickly go over the glossary, and these are the common terms that you would be hearing from my end throughout the session. So power chart is an application used for clinical documentation.
I was calling to schedule an appointment.
Scheduling appointment book is the scheduling application. The PM office is the registration application. Work queue monitor is the application for scanning documents into the patient's chart. Power plan is the order sets. Power form is the electronic form. iView is the electronic flow sheet. Dynamic documentation is the clinical notes that the clinicians document on. The ambulatory organizer, it provides a summary of the scheduled appointments by resource, and message center is the internal application with a power chart.
Puneet, it's Mike Copeland here. Just wondering if you could switch over to the slideshow rather than the version. It's a bit hard to read all the elements on the slide at the current size.
Sure, Dr. Copeland. Does this look better?
Yeah, much better.
Okay, thank you. So the workflow review. So the next few slides is just a refresher what we discussed in the requirements gathering session, and so that everybody is up to speed with what decisions we made. So for the core location name, we agreed that it would show as VGH Renal Hemodialysis Home, and the Nocturnal facility would show up as VGH Renal Hemodialysis Independent Nocturnal. I know we do have the PHC SMEs on the line, so I want to take the opportunity to ask them, is the name for SPH Renal Hemodialysis, would you agree with the same name for St. Paul's as well as we have for VGH?
Yeah, sure. So you have VGH, sorry, this is Dr. Kia. You have VGH Renal Hemodialysis Home, and then the independent, okay. Yeah, no, I think we're okay with just having the St. Paul's Renal Hemodialysis Home. Agree, Bev? Yeah, I think that's good.
Okay, thank you. And the core location abbreviation that VGH SMEs agreed on was VGH HD Home and VGH HD Independent. IND is independent and NOCD is for Nocturnal. So as for SPH, would you agree for SPH HD Home as the abbreviation?
Sure.
Okay.
Yes.
Okay, thank you. Same for clinic flag. So we agreed that the clinic flag would look like VGH Renal Home Dialysis Home. Would PHC Renal Home Hemodialysis Home look okay?
Yeah.
Okay, perfect.
Mercedes, I'm not sure how the naming has been like previously. Is it PHC that we have or SPH?
Hey, Dr. Jung, it's Marissa. It's PHC.
It's PHC. Okay.
Okay.
Yeah, that's the
And I
that's the
think-
standard naming convention for all of the PHC flags, even outside of the renal program.
Okay. And right now for our current nocturnal, we just call it PH, like, I guess it's not a real, it's just attached to our current hemo program. So yeah. Okay. Yeah.
Yeah, the VGH independent nocturnal program is actually part of the home program. That's why it needs to stand separated with us.
Okay. Thanks. Got it.
Okay, thank you. So I'm gonna jump into the providers workflow reviews, future workflows, because we have providers for the first hour. So I'm gonna quickly talk about the message center, and I'm also gonna demo once I go through these slides. So message center is just an equivalent of Outlook. It is the internal messaging center between the clinicians, between providers, between nurses to providers, and basically within the unit. So we usually have two pools of, and when I say pools, we mean that a group of people that are within one pool, and the standardized enterprise pools are clinical and admin, and there are usually clinicians in that clinical pool, and we have clerks and other administrative professions in the admin pool. We do assign a team lead for both the pools, which means that they're usually responsible for letting a person into the pool or letting a person out. A person can always opt in and out of the pool as well, but we do have a team lead for both the pools. So I just wanted to put it out to the SMEs. Would you want to assign someone to the clinical pool team lead? It could be any provider or anyone you would like from the clinicians.
So there'd be one particular person that would be the team lead.
Yeah.
Okay. We'll probably put Dr. Jamal.
For
Dr.
St.
Jamal.
Paul's, and for VGH, it would be myself.
Okay.
Can we have two leads? Because it would be nice for VGH to be myself and Dr. Singh. Or is there only one? If it's one, it can be me. That's fine.
It is usually one, that is the standards design, but I would defer this to the ambulatory team if we can have two team leads for a pool.
Sorry, it's Dr. Kiai. So just to clarify, you have a lead, but then there's also, like, there could be a whole bunch of number of physicians who are on that pool,
Correct.
right? Okay.
Yes.
Like the lead just sort of helps to sort of make some decisions and stuff, but then you can have, like, we have a whole bunch of people on our hemodialysis pool.
Yeah,
Yes,
so
that
it's
is
Maritza. So the leads just kind of help to manage the people that are opting into the pool. So you just want to make sure that you don't get like a weird provider that kind of opts into your nephrology pool of in message center. So that's kind of one of the major responsibilities of the lead. And we did the confirmation that it's just one lead for per message center pool.
Okay, so myself for VGH, and it sounds like Dr. Jamal for St. Paul's.
Thank you.
Can someone from my team please take notes for this? I'm somehow not able to type on the screen. Thank you.
Okay, I got you, Penny.
Okay, thank you. And what about the admin pool? Do we have a candidate for a team lead for that pool?
So for VGH, I think Dan is on. I'd suggest probably Dan if he's agreeable to that. Did I see Dan on here somewhere?
Waived.
Yes, I'm good.
You're good. All right, perfect.
Thanks.
So sorry, can I just ask, like, so the team lead admin, is it usually one of the nurses, or would it be like the patient care manager? Who's usually the team lead admin?
It can be anyone. It's a unanimous decision between the people who are opting into the pool.
Okay.
Yeah.
So I think if we had to say, I don't know who we would choose right now. Can we leave that to tell you later?
Oh, of course.
Okay, thanks.
Can I ask the question, what does that mean? Team lead admin, so they're part of the pool, so they'll get all the messages, or is there some other responsibility?
It's so everybody in the pool would get all the messages. It's just like an administrator kind of a thing that is a team lead. So If a
What would be
person,
their responsibility? Like they're not going to get the messages, are they? Like the clinical messages?
they will get the messages as well. So whoever are in the pool would get the messages, including the team lead.
So I think that Mike, you chose like, who did you choose? Sorry.
Yeah, Dan, who's our he's the admin lead for over in the Independent Dialysis Center. So it would make sense for him to be involved in these conversations.
Okay, we will figure that out.
I would say you'd probably want to choose your operations manager for
Okay.
covering the independent therapy. That will probably be the right person. That would be analogous to Dan.
Okay, so I would say Lila then. Lila Aparicio. I can say the name properly because she'll be the manager.
Okay, thank you. So before I deep dive into the demo, I'm just going to give an overview of what I would be showing in the demo. So firstly, I'm going to show a bit of message center, how that looks like, what are the components of the message center. Then I'm going to deep dive into the provider's view, the dialysis management M page, the HHD, the prescriptions, the quick orders M page, where the providers have their power plans at one place to choose from, the ad hoc labs and provider documentation. I do want to call out that at the moment, we do not have HHD specific content into the system. So I'm going to try to show the most relative content in system that would be mainly HD. I'm going to quickly share my screen here.
Puneet, can I just put in though that is going to be a significant build that will be required. The existing hemodialysis prescription will work for half of our patients on home hemodialysis, but we use two systems, one of which is called the Next Stage system, and it is completely different ordering set than what you would be able to use. You cannot jerry rig and back rig from an existing prescription because of the nature of the equipment. So that is something to flag that we will have to build.
Yes, of course, Dr. Copeland. So we do have that on our radar. We would build a separate prescription, HSU prescription for you.
There'll have to be two, is my point. There'll be two, one for a conventional system, which I'm aware of, and I've used that system, but we'll also have to build one specifically for Next Stage, just to flag that in your work plan.
Okay. Of course, thank you.
Just for PD has two options where it's CCPD and CAPD. So I think it would work similarly for
Agreed.
home hemodialysis.
Yeah, I agree. That's a good analogy, Beth.
Okay. So I have logged in as a provider. This would be the landing page of the providers when they log in, and you can see a message center, which is really equivalent to an Outlook. We have different subsections in the message center. We have sections for results. We have sections for orders, documents, messages. So messages in here, this is one message that this test account provider has received. So once he receives the message, he can open the message. And it looks exactly similar to how it usually looks in Outlook. So from here, you can either reply to that message, you can delete it, you can forward to another provider, or you can forward to another clinician for them to review the message. Other sections of this message center is you can receive orders, you can receive cosign orders. So if a nurse or if any other clinician is placing an order and that they want that order to be flagged or co-signed by the provider, they can select an option for co-signature required. And if they select that option and flag it to the providers, that would come under the co-sign orders in here.
Sorry, it's Dr. Kiai. Can I just ask something from the previous thing that you were talking about, the notes, like the message that they send and you reply or whatever? Can you just make sure, like, I think you guys have fixed it, but previously it would save to the chart each time, just to make sure that doesn't happen. Like before, what it was is that it automatically would save to the chart. And so we asked for that to be removed. Like every time like you respond back, it would save to the chart, right? Just make sure that's not happening. That was a pain.
Okay, so Dr. Kia, as per my understanding, that should have been resolved because we do have a save to chart option, but I
Okay.
can definitely take that back to the team and investigate.
Okay, perfect.
Thank you for that. So cosign orders, all the cosigning orders would appear in here in this section for the providers. If there are any documents that have been sent by any of the clinicians for you to review, it's gonna show up under this section of the message center. And we have other sections. We have a section for reminders. So if you want to set a reminder for yourself, what the workflow is, you see this communicate button. You select a reminder, and then you can place a reminder for yourself. So you select the patient for which you want to place a reminder, and then you can fill out these tabs, and it's going to give you a reminder based on the settings that you do.
Because I need to do my pre-visit check.
So this is the pools that I was talking about. So we do have so what we discussed was we're going to have two pools for the home hemo clinic. One is going to be the admin pool and one is going to be the clinical pool. And this is an option where you can manage those pools and you can always opt in. There's a section for opt in and opt out. So once you're in the pool, you can always opt in and opt out of the pool. Okay. This is another functionality of proxy. So for example, if a provider is going on vacation and they wanna assign their work to another provider or assign their patients to another provider, we do have a proxy list. So for example, if Dr. Copeland is going on a vacation for 2 weeks, he can just proxy another provider to look after his patients. And this is the functionality that would give him the opportunity to do that.
So you're giving me 2 weeks off, is that what you're saying? Thank you.
Yes. Okay. I'm gonna quickly jump into the patient chart. Search for the patient here. So write patient, write encounter. You say okay. So this is how a patient's chart would look like from a provider's view. We have different sections in here, which CST calls M pages. And then we have a table of contents on the left side of the screen, which is usually called the menu. The M pages are customizable. So a person can go in and customize how their M pages would look like, but the table of contents, that is the menu, is pretty standard. So once you go in, there's a patient label banner, patient banner on the top. You can see the information. This information usually gets pulled in when the patient is being registered. And then we do have all these process disease and isolation alerts that will show up on the banner bar. This is where the abbreviation of your facility or of your unit would show, like the abbreviation that we desired, GHHD, IND, NOCT. This is where that would show up. So we do have a dialysis management M page that is personalized for renal clinicians. So this is how that M page would look like. And if you go into the section of dialysis prescriptions, we have this drop down where we currently have the 3 prescriptions that are inbuilt, and then it would have home hemodialysis prescriptions as well. So the workflow for a provider to enter a prescription is they're going to go inside this dialysis management M page, they're going to select this drop down, and they're going to select the prescription they want to document on. So for example, let's say we want to document a hemodialysis prescription. This is how the prescription looks like. It is pre-filled with some content because I already have a prescription filled for this patient. So it is pulling over the content that I had from the previous prescription. But you can always go in and change based on the clinical judgment. We do have locations for VGH in place now in this prescription. So we have outpatient VGH and we have inpatient VGH. There is, so you can change the prescription as many times as you like. And as you change the prescription and sign the form, the new prescription or the updated prescription would show up under your dialysis prescriptions. So this was the prescription earlier. This is the new prescription that I just edited. So it's going to give you the time and date of when you updated the prescription. This dialysis management M page also has other sections to it. So it has these vital section, which usually pulls information from iView, where nurses usually documents the vitals and does all their documentation. So most of the content that is documented in iView gets pulled into this dialysis management M page.
I have some questions about that because like Mike, for the independent nocturnal hemodialysis, the patients, I guess, have their own records. So I wonder how that's going to work, how the entry of this blood pressure information is going to get into the record.
So the independent nocturnal patients just do a reading at the beginning and the end. So that won't be a problem. That would be, I guess, would have to be picked up by the nurse to then enter it at the beginning and the end of the run. Dan, does that sound right to you? Or others? I guess Alberto's on too.
I mean, if I were to say anything, these patients are independent and they're supposed to be monitoring their own stuff. I don't think the nurses do keep a log of their current logs. It's all the nurses that keep their own logs in their own lockers. So it's part of their own stuff. Same as patients at home. So current state, nurses are not logging their current run sheets.
It actually raises a bigger question for the home patients in general as to where we capture this information or if we need to, because the bigger question, I mean, the nocturnal patient is a small number of people, but the home patients would not be capturing it. So.
Okay, thank you for that clarification.
Yeah, I guess you have to decide if you want it in the Cerner record, how that's going to be entered.
I think it's going to have to be, because as I say, our independent nocturnal program is really an extension of home. So I think it would be the same approach we'd use for at home. If it's not reasonable to have people enter it at the beginning and the end of the run, that's not within the current role for the nurses, because as you point out, the patients are self-managing their monitoring. So I think it can stay out.
Yeah, because like they're almost like PD people, right? So in between clinics with PD patients, we don't have records of their blood pressures on a daily thing, right? So it would this part wouldn't exist for the home.
That's correct. And actually, the patients bring in their flow sheets with them to the clinic, so that's where we actually look at what's going on, not on a record. So.
I think the only time we would be documenting is when the patients are on site doing training in center, or like if they were inpatient and getting dialysis, then the nurses can document into Cerner. But for the patients doing it at home, it'll just be status quo. They'll be continuing to do it on their paper logs.
So this stuff could go in during their training period.
Yes.
Because the nurses would be putting it in. Okay.
Yep.
Is that correct, Alberto? Because
yeah, I was going to add to that, because technically we are teaching the patients to do their own monitoring. So eventually that's what we want them to do. So those logs are actually for them to take at home. So right now, current state, we are not keeping a log of their stuff during their training. Those papers are for them to take home so they can see what their progress was during the whole training phase. So as I was thinking before, it's like, I don't think it'd be something that we would be putting in, because really we teach them to do their own monitoring pretty well within like a week of their training already.
Yeah.
But could you, even though they're filling out the logs, couldn't the nurse then, as because you're with them during their training, right? Could you not put it in? Because then, if as the physician who's coming and assessing the patient to see during their training period, if you reach where you want, they have to have something to look at, right?
We have that, right? Because they're noting it on paper. So that's how we would actually look at it in the current state, that they would go to the patient and pick up their clipboard that they're self-completing.
Yeah. So then, Mike, honestly, you would then either have to like download those log sheets into Cerner somehow, or if the nurse could actually put those vitals in, it's almost like during their training, just during their training. I'm just trying to think, like, for you as the physician.
But the question is, I don't know we'd need to, right? Because that wouldn't be, philosophically, I hear what Alberto is saying. Philosophically, we're actually not training the patients to be Cerner savvy. We're training them to be writing it on their piece of paper at home. So we try to replicate that right from the get-go with them in their training.
Mm-hmm. I guess the only advantage that would give it to you during just their training is that you could remotely look and see what's happening, right? You could see, okay, that run, this is what their blood pressure was like. This is how much fluid they took off, right? But that would be the only thing, right? But
yeah, so
it's not crucial.
Yeah, I don't see any value of it from seeing people training at VGH. If there are patients training in East Van and Richmond, that may be a flow that would have to happen there. But again, with the idea that this is going to move in-house to St. Paul's, I think that will become unnecessary within St. Paul's too. Unless you choose to do it that way, obviously.
Just a quick question. Do the log sheets during the training program ever get like photocopied and kept in their chart?
No.
No. So it's just kind of the patient takes it home and then you train them to monitor.
Yeah. That's
okay. Thank you.
I guess the only time blood pressures could be entered into Cerner is on their clinic visit. Is that correct?
So we would be noting it right now in terms of just in our clinic note, as opposed to necessarily entering it anywhere else. So it's data that comes to us on paper form, and we look at it, and then it gets included sort of in our summary note of what's been happening. We're not actually capturing it anywhere else currently.
Yeah, you like, it's very much like a kidney care clinic visit, right, Bev, or a PD clinic. When they come, the nurse sees them, they put the vitals in, the dietitians will put their note into Cerner, and then you do your note on Cerner.
Right.
And yes, you'll document, but
yeah,
because it'll be like pre-populated for you, Mike. So
right,
you don't even have to put the vitals in. As soon as the nurses put in, boom, it'll go into your note, right?
Mm-hmm.
Except that it's actually not. If we're talking about pre, post, and intra HD vitals, that
No, not that.
No,
just like a clinic visit, right? When they come.
Yeah, correct. That's right.
The only time that wouldn't happen is if it's a remote, right? If you're doing a phone call visit, right? But yeah, if they come to the clinic, then that's what happens, right? Just like kidney care clinic. Right?
If I were to add current state for nursing and allied health, they all chart on promise for clinic visits.
Yeah, that will probably start to change. So I think for the purposes of this discussion, for the independent nocturnal at VGH and for the home patients at VGH at least, and I won't speak for St. Paul's, I don't think we would be recording their vitals here other than during clinic visits. So.
Agree.
And I think there is a role, at least in an interim measure, that for the patients who are training in East Van and Richmond, that if there's the capacity for those nurses to enter at least some of the dialytic vitals in, then that would be helpful. But that I think you guys would find at St. Paul's you would not need ultimately when they come in-house to St. Paul's, whenever that happens.
So Dr. Copeland, what I'm hearing is even when a patient is training, the nurses would not be documenting their vitals?
So at VGH, we would not be, and a decision will have to be made from the St. Paul's how they want to handle that. But I think there would be a role for them to be documenting the vitals in, at least as an interim measure, in East Van and Richmond, but we would have to talk with them because that's not part of their normal flow right now. So we'd have to approach the nurses about that out there.
Okay, thank you. Good to know. Can someone from my team please take a note of that? That would have a little bit of impact on the workflow. So moving forward, the dialysis management M page is customizable. You can move in the sections up and down based on what you'll be looking at more often. And there's also a section in here at the top right corner of your screen which says components, and you can always pick and choose and drop what components that you do not want to look at you don't want to see in your dialysis management M page. So if we scroll down, we do have a few clinical notes that a provider can document on, like the provider clinic note. And we did have some, so all this information, if it's documented in Cerner, this note is going to pull in the information into this clinic note, and then the provider can always save and sign and submit.
But Puneet, Mike can start to make the proper home hemodialysis note, right? Because this wouldn't fit, right?
Yes.
Start to make it.
We have a standardized way of doing our letters, so.
And
Yeah, so a template should be created for the home hemodialysis program.
Yeah.
Yes,
So
and
you
we
can
do have that content coming up later during the presentation.
Perfect. We're very formulaic in our notes, so.
Okay, of course. So these are a bunch of options where a provider can document their clinical notes, and we would have auto text created very specifically for HHD. So the other M pages are the outpatient orders where the providers can find their home hemodialysis orders. So at the moment, we do not have a subsection for home hemo, but we do have sections for hemodialysis, and we do have a section for PD. So this is where all the power plans live at the moment, and we can create additional section for home hemodialysis power plans so that it is easier to locate the power plans for the providers. So what the proposed workflow from Cerner is, a provider goes into one of this outpatient quick orders M page, and they select, for example, if they want to select NEF hemodialysis initiation treatment, they select on this power plan. There's a shopping cart sign in here. You go into this, you select this cart, you say modify details, and a comprehensive view of a power plan would show up on your screen. So this is how the power plans would look like based on if it's a day of treatment or if it's a multi-phase or if it's a single phase ongoing, and that discussion would happen in the order set section. But this is how your power plans would look like. There are a few orders that are pre-selected, but you can always go ahead and uncheck them if you don't want that orders to be placed on that patient. So this is currently the adult hemodialysis power plan. So it has some orders pre-selected. It has microbiology, virology, it has diagnostic tests, and it does have a scheduled hemodialysis order. And when we move further in the design, it would have scheduled hemodialysis VGH so that the clerk can schedule the patient for dialysis.
So is that, so that'll be important, obviously, during the training. At home, do we need to use the schedule to capture the number of runs, or because that's going to be important information to feed back, I guess. But I guess the scheduling is less important in terms of when people are at home for that, yeah?
Yes. So do you usually keep track of the schedule during the current state of the patients when they're transitioned back to home?
We would try to keep track of hours dialyzed and frequency of dialysis treatments, but not necessarily a schedule in the traditional sense, because they do it at their own time frame.
Okay.
I think we would just keep doing that and promise where they have a permanent schedule. But I don't think we need to actually schedule it into Cerner. As long as Promise still has that information, we should be fine. Yeah,
and I mean, the frequency is a little bit less important for home because it's a weekly it's a weekly capitated fee that comes into the hospitals as opposed to per treatment, I believe, but we can double check that.
Okay, of course. So this is how some of the power plans would look like. This patient does have a peritoneal training power plan placed. So I believe this is the power plan that would closely mimic the HHG training power plan, in which it is a day of treatment power plan, and it has separate day of treatment components. So the same thing, the provider can go in and provider can select what orders he wants to place. He can check and uncheck based on a patient's treatment plan. So this is how some of the home hemodialysis orders would look like.
So Mike, I think it's just basically the home hemodialysis admission orders. If you have like a PPO for that, about what kind of lab work and things like that are being done during their training period, that's what I think the power plan will be required for.
Okay, yeah, we've got some PPOs for that.
Okay.
Just so, again, so you are aware the differences with PD and home hemo, our training is definitely longer than PD. So just so you're aware, we will be having usually 6 to 8 weeks of training, 3 to 4 treatments per session. So it is going to be a slightly more unwieldy power plan, just as you guys are thinking that through.
Yes. So this was just a power plan that I found that could be similar to, but yes, home hemodialysis would definitely be more. It would have more phases to the power plan because.
And I just remember hearing stories about freezing the whole hospital system at St. Paul's when the hemo plans were activated. I don't want to get into the same sort of challenge here with this.
Yeah, and I don't really think you need these columns where there's days of treatment. Your home hemodialysis admission order should be similar to what we have for our hemodialysis. I don't think you need to have these columns like PD has.
Yeah, I agree.
Dr.
Definitely not.
Dr. Copeland, it's Carrie. I'll be helping you with the power plan and the order sets.
Okay.
And I understand what you're saying. For most of your home HD patients, they're generally chronic patients transitioning to home HD. Is that correct?
Yeah, that's true.
So right now the plan is, if you guys are adopting the facility transfer workflow, where you're keeping the same encounter, but the patient is just going from chronic to home HD, then technically all the existing power plans, so the admission, vaccination, adjunct, and everything like that, that was placed for a chronic patient, will carry over when the patient's home HD. And the power plan that Puneet is showing right now, that is more specific for PD. When I was looking at your PPOs, it didn't really mimic the same type of format. So I think what's going to happen is, like Dr. Jung said, your current PPOs most likely mimics the admission power plan. So when the patient transfers from chronic to home HD, you don't necessarily need to reorder anything. But there is the initiation power plan that has the diagnostic test in there. So if you need to place that, that is available. But,
yeah, I think that's a much better way to do it, Carrie, because you're right. We do have essentially a requirement of at least 3 runs in center hemo before coming to start training. So by virtue of that, that would be the place to activate all those plans. And if those can carry over encounters, that would be ideal. And then you're right, it's a relatively limited set of home specific elements that we'd have to build in.
Okay. And I'll talk more about the different options and like the workflows in the order set sessions.
Perfect.
Okay. Thank you, Carrie, for the clarification. So this is where power plans can be found under the order section. We do have a bunch of other M pages, but you don't necessarily have to document on those. The most common M page that the providers would be documenting on is the dialysis management M page. Okay, I'll quickly move back to my PowerPoint. Okay, so day of clinic visit, we just demoed what it looks like, the message center, the M page, the prescription, and the order sets. So we do have some content later in the session where the PET team would talk about the auto text that they would specifically create for home hemo. But I wanted to quickly talk about the referral order. So we would build in a referral to outpatient home hemodialysis order, like we have the outpatient renal vascular access. It's not in the system, but it's going to look something like this, where any provider can refer a patient, placing a referral to outpatient home hemodialysis unit, and it would look like this in the system. And once they place the order, that order will route to the home hemo queue for the clerks to schedule the patient for the pre-assessment clinic. We would have follow-up orders as well, and I can quickly demo how it would look like. So I'll just quickly go back in the power chart. Find the patient. So the workflow for ordering a follow-up clinic can be that the providers can go in and ad hoc and order from the orders catalog and just type in. And the way here it says follow-up clinic kidney care, it would say follow-up home hemo clinic. So you can select this order, and this is how the home hemo clinic order would appear. Sorry. And it would have all this DTAs to be filled out. You can fill out the requested date, the reason of follow-up, appointment requested, and the appointment requested drop down would have different appointment types for home hemo.
You know, I've never done this before. Is this something the UCs would do when we plan a clinic for, say, our nocturnal patients? We do have clinics every 3 months. I've never done this.
Yeah, I
Entered an
agree.
order. So is this something the UCs do?
Like, when would we use this?
So the place I could see this being relevant, this doesn't make as much sense to me from a clinic point of view, unless we need to do that as part of the scheduling element. But what it does make sense to me for is that this would be how the referral process into the program as the first point of contact of the home program would work, where a provider from hemo could put in this referral, and then we would schedule into the assessment clinic. Is that what you're thinking this is more for?
So Dr. Copeland, we would have a separate referral to home hemodialysis order. This order is to schedule like a follow-up visit for the patient. So
to Bev's point, is this currently being done by the UCs then? Because right now, current state would be I would probably verbally tell the nurse or write in their paper chart follow-up clinic in 3 months, and then they would be scheduled accordingly. So this would be something that would be captured by the UC, or how would this be done?
So can I just say, I don't think anyone is doing this right now because home hemo isn't live. So the home hemo clerks weren't doing this. For example, though, in kidney clinic, in our other session, it was brought up that it is a verbal communication. However, patients could fall through the cracks because if it's just a verbal given, these patients don't show up on a request list for the clerks to schedule. Whereas if we're putting in these follow-up orders, it does fall onto a request list for the clerks, and they'll know to schedule without you having to verbally tell them. So it's just a different workflow to ensure that the clerks know which patients to book for a follow-up appointment.
I mean, I agree with Dr. Jung. I would love to know, when has this ever been used at St. Paul's?
And I would also say that I don't see that this scheduling function should be a provider function. I don't think it'll get done.
It can be, the follow-up order can be placed by anyone, but yeah, I think this is just something that operationally has to be discussed on how the follow-up order goes in and who's to place it. But the main reason for it is so that the clerks know who to book and they don't miss booking patients for follow-up appointments.
Can I just add, for at St. Paul's in the vascular access clinic, the nurses are actually putting this in for the vascular access, and then
So
Colleen
I'll
would
be
book-
honest with you, the nurses do not put that in. It's the unit clerk who puts it in. That we don't, they don't, the nurses don't put it in. And me and Bev are both doing KCC, and I've never even heard of this.
Yeah, KCC isn't using this order,
No.
that's why.
Yeah,
Yeah.
and we don't use it in vascular access either.
So how are they
So-
scheduling in KCC? Because that's going to be the same mechanism we do.
So
it.
we have a meeting at the end, or at, like, basically in our note, we'll put down 3-month visit, and the UC will also talk to us because they're right there. They'll, as the patient's leaving, they're like, when do you want them to come back?
Yeah,
And
so
so
that's
we will say it.
that's how we're doing it right now,
Yeah.
functionally with the home clinics.
I do think it's important to have a referral, like for vascular access. We can put in a referral through Cerner. So there should be a referral to home hemodialysis and a choice of either site.
Yes, there would be a referral to home hemodialysis order in there, Dr. Jung.
Yeah, and the vascular access is important, absolutely.
Okay. So what I'm hearing is that it's unlikely that you guys would be using this follow-up order to schedule a
Well,
follow-up.
I'll say it's unlikely as a provider, I'm going to be using it. I won't
I
speak for the rest of the team, but as a provider, this is not something that I'd be probably jumping to be doing.
Okay.
Yeah, I think we agree. And then I just wonder whether then it would, because if it can come up for any provider, then I don't know, all of a sudden you might get funny orders by other people, right? Do you know what I mean? Like someone like on CTU will be, oh, this person needs to have a follow-up in the kidney clinic, and maybe they've never been referred. So they'll go in and they can do this, right? If they're a provider, they'll be able to do this, and they'll just cause a lot of confusion.
I believe there
Yes.
was you can actually refer to the kidney care clinic. And so I think there was a referral through MSJ just directly to the KCC, to St. Paul's. So that can be done.
Yeah, I guess what I'm saying is that, like Mike is saying right now, clinicians we're not using this. I don't know who's going to use it, and I don't know if it's going to cause confusion.
Okay.
Not to say that the scheduling is not important. It's a distribution of who's doing the workflow.
Okay. Okay, I can take this back to the team and we can investigate if this order can be hidden, or if UCs can be given access to.
So sorry, Marissa, I just got word that we could likely virtual view these follow-up clinic orders, so that's only available for the clinic and the clinicians within the clinic to use. So to your point about like a random provider using this inadvertently or inappropriately, we can make sure that that doesn't happen.
I think,
Yeah.
Maritza, this is already virtual viewed by the kidney care clinic, but we can double check. So this
Yeah.
order would not be viewed by another clinic to put in.
Yeah, so just be aware that this order is available to if a follow-up appointment is required in your clinic, but if you choose not to use it, that's okay too. It's as long as you have like a system of ensuring that follow-up appointments are booked by your clerk for patients needing to come back to the clinic.
Perfect. Thank you.
Yes. Thank you for that. So just being mindful of time, we do have another piece that Pet wants to cover. So I'm gonna hand it over to Didi to talk about this section. Didi, are you on the call?
Yes. Hi, can I get the ability to share screen, or if you're already in PowerChart, you can hop into the free text note as well.
Yeah, can you share your screen now?
Oh, yeah. Okay, perfect. Can everyone see my screen?
Yes.
Yep.
Okay, perfect. So we do actually have existing hemodialysis clinic notes. So these are the auto text. I'm just in the free text note. And then these are the renal. We do have the HD clinic note and the HD clinic. I'm just confirming that would these not work for the home hemodialysis clinic?
The HD, I think the HD clinic note can be a very good starting point for it, for sure. There's going to be some elements that we need to adjust in terms of the dialysis prescription on it. But again, if that can be all pulled in from the existing prescriptions, I actually think many of the elements that are on the, I'm very familiar with the renal or the dialysis clinic notes. I think that can work quite well for us.
Okay, this one, the other one is because we had two in the system. We had renal, renal, oops. We had the renal HD clinic and then the __ HD clinic. No. So this page that I'm on right now is the renal HD clinic. So wondering which one we wanted to base the home hemo off of.
Can you show me the other option as well?
Yep.
I've always used the HD clinic because I use the first one that shows up on the list. So
I see that there's actually an HD clinic note VGH. That's
that was
listed.
the one we prototyped, but then we realized that we already had two existing HD ones. So we wanted to check with you guys to see if we can.
This one has nothing on the vascular access from what I can see, which is fine, right? It just says what the access is. But if you go back to the other one, I'm just trying to look at the difference because honestly, I'm confused which one is which one too. It just tells you about the last access flow, last fistuloplasty, which not appropriate, right? For you.
Yeah, this is the one that I'm actually used to using. And I think this is the one that largely could be replicated for our template. It's very similar to what we're doing currently.
Okay, in that case, I'm gonna close this one out. This one would be the renal. So it would be the ones without the underscores. It would be this one. So if it's for home hemodialysis, will we need to modify anything on this note? Or can we make it like an enterprise one that can be used by both home hemo and HD?
I mean, I think the elements are all the same as with HD. So I have no problems actually keeping it as a single note that's used across the modalities, as long as we're, and just to confirm that if it's a next stage patient, the next stage prescription, when it's built, will pull into this, like we have the hemo prescription pulling in right now, right?
If it's on the dialysis prescription component, then it will pull in.
Yeah, so I think this is really quite similar to what we're already doing. So I think it would be fine for us to just use this same free text note for our clinics.
Perfect. Thank you for confirming. So I just wanted to go back to the prescription piece real quick because
but hang on, before we do that, can I just make sure with some of the home hemo nurses, as you're looking at it, if there's any elements that we aren't including that should be, this is probably a good opportunity for us to see if there's any changes, but I think it captures pretty much what we need.
Can you go down a bit? Because that part about the pre and post hemo vitals that you can just delete out, Mike. You can
just delete it
out. Yeah,
exactly.
Yeah, you can remove that if you like.
And Mike, you can actually make a template specifically for yourself. You can just copy this, modify it, and save it. And then instead of comma, you can name it period. And so you can look this up, and it's specific for you, saying it was seen by Dr. Copeland. Like you could make your own template for yourself.
I don't have to type my name in without an E all the time. I'll miss it though, because I always think of Boy George when I say comma. Sorry, I know that like 50% of the people on here have no idea what I'm talking about, but there you go.
Culture Club.
Culture Club, there you go. Raise your hands if you know what we're talking about. Yeah,
Okay,
no, I think this is fine. You know, I think once you get used to using the template, it's actually fairly easy to use. And I think it meets the needs for everything we have in our clinic. So I think rather than having multiple things that get chosen inappropriately and then get labeled wrongly, just go with it. I'm totally comfortable with that.
Perfect. Thank you for confirming. So we'll make a note of that. And then I just want to quickly go back to the outpatient quick orders page for the prescriptions, because Dr. Singh did request the Alta plays. And I wanted to confirm that it's in the right folder that we want it to be. So I put it in medications. Is it supposed to be in anticoagulants?
Yeah.
Okay. And then just to confirm, I want it to go. Into the details. I basically copied the order sentence from, just hovering over this, from the prescription sheet, and I just wanted to confirm the order details are correct.
This is Winnie here. Is that order comment necessary? Like in terms for a nursing perspective, like the mixing information is usually in shop. The reason I ask this is generally as providers, when we're ordering these medications, we use the order comment section to notify, like if it's meant to be, once a week or every run. And so it's nice to be able to leave that order comment blank so that we may add certain information that may be specific for the patient. And so mixing instructions can be somewhere else instead.
Hey, Winnie, it's Carrie. I found this PPO when I was doing gap analysis with Dr. Singh. I think the prescription or the PPO is actually faxed to McDonald's and the order comments gets transcribed for the patient. This is to be administered by the patient at home.
So this would be for their TPA that they're self-administering at home as opposed to in the unit.
Yeah. Mm-hmm.
Oh, okay, because I see the frequency of once. That's why I wasn't as a default.
Yeah, so you're absolutely right that there may be situations where we're scheduling it once a week. And I guess the other thing I would just comment on is that this looks like you're then filling both the arterial and the venous port. And there may be times that we may be doing one or the other, not both. So that would probably need to be captured as well. And do we need to do something to clarify it a little bit more? Because obviously if Winnie is confused by it, then everyone will be confused by it. So this would be for patient self-administration at home to differentiate it from when they're in their training or in the clinic where we would be.
Yeah, I think that'd be important just because where it's living right now in the physician screen for like that quick access, it'd be really important to kind of have more information there so that if a physician were to click on this as an outpatient prescription, it'd be highlight maybe in the special comments that to be dispensed for home use or something like that, can be pre-populated so there's no confusion.
Can we add that in maybe the first sentence of so
I just see the special instructions there. Yeah, like I would just pre-populate it there. So it's like for home use or something, or for home HD patients or something like that.
Home HD patient self-administration.
Yes, please. And then if the frequency could be left blank, just so that it's not once, so that when a provider is ordering it, then they can make a conscious decision about how often or how frequent it would be administered for the patient at home.
And I'm just seeing all the infusion things coming up there as well. That does not apply at home. It's only a dwell that we would do at home. We would not do an infusion.
Yeah, so
I think I changed it by accident for, hold on. So in that case, other than adding the special instructions, we can remove the route of administration. And then what about the dose?
I think it's the frequency that's most important to remove. Okay. Yeah. So that it's a conscious
we'll
decision.
just take away the once and that's gonna be okay.
Yes, please.
Okay, sounds good.
And I think if this is meant for home use, 2 milligram per vial dose would be probably fine because you're going to be dispensing a vial at a time for home use anyways for the pharmacy. So it'd be more clear that way.
Yeah, we would often be dispensing for people, especially the ones who are needing it more frequently. We dispense a variety of them, so they have them on hand. So
Okay,
yeah, the 2
sounds
milligram
good.
per vial is right, but no infusions. And then that comment in the special instruction about restricted to self-administration for home hemo patients.
Okay, we'll do, and we'll add that in. And then in terms of the placement, it would be correct under medications and anticoagulants.
Yeah, can I ask, is IV the right term for it? Because it's not really IV, it's actually a catheter dwell and then hopefully aspiration of it. But is IV the standard format for describing that? Yeah, even though it's not really IV. Okay, I'm seeing Bev nodding her head, so.
Yeah, no, there isn't another term for it that's built in. So we've been using IV.
Okay, thanks.
Okay, thank you for confirming. So I'll pass this back to Puneet.
Thank you, Didi. I know we're at time, but can the providers just stay 2 more minutes? I just need one more confirmation.
Yeah.
Okay. Thank you, Dr. Copeland. So I just wanted to confirm, this is one of the assessment referrals that we found from our Confluence page that was given to CSD. So this is a referral that you are faxing for pre-assessment clinic. Is that correct?
That's correct. This is the referral into the program.
Okay, thank you. And this is the last slide.
So sorry with sorry, go ahead and I'll see if you capture my thoughts.
Okay. So this is the last slide that I had for the providers today. Just from a workflow perspective, I just wanted to quickly confirm that all the treatments or procedures that are being taken that usually take place in the home hemo and nocturnal clinic are listed in here. That is referral. A patient can be referred to HHD, then there's HHD training, there can be clinic follow-up, there can be transonic monitoring, respite retraining, a patient can be transferred to inpatient from a home hemo clinic, and then usually when patient travels, you give out the travel letters and then the facility transfer. Am I missing something that I have not captured that does happen in your home hemo clinic?
I guess there's the formal HHD clinic follow-up, but then there's also ad hoc follow-up that may be happening. So that would be some workflow for the nurses in particular.
Okay.
So I think we should call that out because there's a lot of telephone calls that go on related to that.
Okay. Thank you. Can someone from the team please note that? Yes, so that's all I had for providers. I'll give it back to you.
We can come back to this. So a couple of things that I'd want to just make sure we're capturing on this. Number one, this has been to a single referral site. So we'll now have to put this to VGH or to St. Paul's with the changes of how we're doing it. So we'll have to add that in as one of the elements on this. And the other part that we've always had for our HHD referral is that it's not a provider specific referral. It can be anyone on the team, any of the health disciplines on the team. So I'd want to just make sure that that's not a restricted referral to providers only.
Okay. Yep, I'm taking that note.
And so the second page there, particular with respect to some of the phone numbers and whatnot, there's going to be some differences there because people will now get referred for an assessment at the St. Paul's home hemo clinic or the VGH home hemo clinic.
Okay, we would have a referral to the outpatient home hemo clinic, but we would have to investigate if we can put this information in that order or we can put this in this form into form fast. That's all I had for the providers. Yes, so you're happy, feel more than free to stay on the call, but
Hey, Puneet.
free to go. Yep.
While we still have the providers on, can we just quickly talk about the facility transfer piece?
So Flo, we did have that in the agenda for today, but CST is still doing some investigation on facility transfer workflow. So I do have that slotted for the next session.
Okay.
Yeah.
So I did actually have a quick question for the providers if they're still on. Maybe more because with St. Paul's transitioning the home hemo program back to in-center, has there been discussion about whether the current kind of referral triage process will still be used?
So we have had, so from my point of view, from a regional perspective, the answer to that is yes. It's going to look a little bit different, I think, than what it is right now. I don't think we have the final sort of plan for how that's going to look yet. So, I mean, I would still very much like to be able to have it as a regional inflow for patients, and then sort of we distribute patients between the two sites from there. But I think we have to work out our workflow still.
Maritza, I don't understand though, like, so like, I don't understand your question. So for example, like, let's say, like there's a home hemodialysis referral, right? Oh, I see what you're saying. Yeah. So I think, yeah, we're going to be talking about this more, but I think what we were thinking is that if there's a patient at St. Paul's and there's a home hemodialysis referral, it would go into the St. Paul's program for assessment, but it would regionally be looked at still by Mike, but that because patients may have to go if there's a big wait list in one place versus the other, right? So yeah, so we'll probably have to get back to you about that, but that's
that's exactly what I wanted more like information on. I wasn't sure St. Paul's wanted to do their own kind of referral process that's separate, but it sounds like if you still want to keep it like a regional. Like,
well, we don't know
program.
that yet because we're trying to figure out workflow, how it will work best, right? So is there a way though for us to have like in the home hemodialysis referral for assessment, we can have a checkbox to say St. Paul's versus VGA, like so that in case there's like a less wait time or whatever it is, like, I don't know, we can figure this out later, but yeah, I think like workflow wise, we were thinking that would be the easiest workflow.
Yeah, I mean, ideally on this assessment sheet, that's what the point I was trying to come to earlier, that, you know, just like with a transplant, you have a referral to VGH transplant or a referral to St. Paul's transplant, that you would include on here that I'm intentionally making a referral to the St. Paul's program. I think the workflow that flows out from there is that if St. Paul's has an 8-month waiting list to train somebody and VGH has a 1-month waiting list, then we would make some internal decisions regionally to redistribute where that patient goes and does their training. But in terms of the intake, I think it's as long as we can identify where the patient's coming from, so which program or which facility they're coming from, and where the referring person is sort of in their mind referring them to St. Paul's or VGH, that would be sufficient, I think, for the Cerner. And then we can, that would then come more into the facility transfer discussion, probably from Flo's perspective.
Mm-hmm.
Comment.
Yeah, I think that it's just like, I think Mike's example for the transplant stuff was good because some of our patients will choose to actually be referred to the VGH transplant program. So we refer them to that program, right? So I think if we have that option with the home hemo as well, then we can do that. And then as Mike is saying, we're going to have our monthly discussions with Mike about where the patients in terms of like availability of space. But in terms of referring from here, we should have the option to say like St. Paul's versus VGH, depending on what the patient's best choice is.
Okay, thank you.
Does that answer your question?
Yeah, at least it gives me an idea because I just wasn't sure if St. Paul's wanted to do like their own kind of referral process, but it sounds like, again, you want to very much keep it a regional current state, but we just have to fine tune some of the transition points when St. Paul's moves everything back in center. But overall, yes, it does answer my question. Thank you.
Okay, perfect.
But Marissa, sorry, is that going to be an option though? So I didn't understand what you just said, right? Like, I guess what we're saying is that in the part where we go into Cerner, we put that hemodialysis, home hemodialysis referral, right? There should be a part that it can say referral for assessment at St. Paul's.
Yes, we can look into building that in.
I think what I'm hearing is you just want a scheduling location to either choose St. Paul's assessment or VGH assessment when you're putting in the referral. And then there'll be a drop down and you can choose either or. So say if I chose VGH, then it will route to the VGH clerk and they'll schedule it. But if I choose St. Paul's, it will route to the St. Paul's clerk.
Yeah.
And that will be part of the referral order.
Yeah.
Flo is so fluent in CSTE stuff.
Mhm.
Yes, that's right. That's exactly right, Flo.
Yeah.
Okay. Well, thank you to the providers for joining, but please feel free to stay on for the rest of the session.
I unfortunately have to leap away to go and do my day job now. So thanks,
Okay.
everyone.
Thank you.
Thank you.
Thanks.
Okay.
I guess we're still deciding about whether we use the form because a lot of the information would be in Cerner, like their diagnosis, their comorbidities. You know, you don't have to fill in all that information again,
I
right?
don't, absolutely. I mean, the whole like advantages of being on Cerner is that you don't have to do these forms, right? That
Right.
it would just be like,
It sounds like we're building a referral order and trying to mimic the form into Cerner. That's the plan.
Exactly. Yeah. And we'll include the different scheduling locations like Flo mentioned. So.
Mhm.
Okay. All right. So I did receive a request from the dietitians that they do have to leave at 11. So I just slotted their part first. Are the dietitians on the line?
Yes, I'm on the line.
Okay. So day of clinic visit for the dietitian. Before going into the system, I'm just going to talk about the different M pages that you guys can see. You guys can see the results and results review. How can you manage your multi-patient task list and the various power forms that you can document on. So quickly dive back into the system. So this would be your landing page when you open a patient's chart. And as discussed earlier, Cerner has M pages personalized for every profession. So for the dietitians, we have this nutrition workflow, and it has different sections it has different components that pull in information from iView, and then so you have a consolidated M page to view all the information. We do have this clinic specific, the nutrition care plan specific initial note and follow-up note. So if you're seeing the patient for the first time, you can document your clinic note for that patient, the nutrition care plan, and these sections would pull in information from iView if it's documented there. Okay. So, and then if you're seeing the patient for the second time, you can document a follow-up note in this section. There's also a iView specific nutrition care specific dialysis navigator band that you can document on. So as you can see, there's a bunch of assessments that a dietitian can go in. So for example, the allied health assessment, it has all these sections that you can document: composition, oral immune therapy, total feeding intake, feeding output. So the nutrition, we have sections for nutrition diagnosis, nutrition interventions. So yeah, you can go into iView and document your findings in here. We do have orders that the dietitian can place. So the orders usually that look into this, that the dietitians place in the system, are the diet orders. So if you go into the orders catalog and search for general diet, this is the order that appear, and then you can say Physician. So this is the general diet order that you can place for your patient. So it has a requested start date, and then you can always add in the fields. You can add your texture modifiers. You can add the thickness of the fluid that you want for the meal for the patient, and then you can always sign this order to place a general diet order for the patient. Okay. We do have consult and follow-up orders. So the workflow would be the same. You would go into the orders catalog and you would say,
It's dietitian with a T.
Thanks, Flo.
I think we do just RD consult.
sorry, what was that?
It's RD consult or something.
Yep. So this is the order in here. So if you want to place a consult order, you can go in and place this order for yourself, and it would appear on your multi-patient task list. We do have a diet follow-up order as well. So if you've seen the patient for the first time and you want to place a follow-up order, you can go back into the orders catalog, and I think it says following dietitian following. Yep, and this is how your dietitian follow-up order would look like. I do want to show the power form that dietitians usually document on. I'm not sure why there's no ad hoc folder in here. Sorry, let me do one thing.
Is it on their M page?
It should be under the, yeah, let's check. It should be, there should be an ad hoc folder for the dietitians.
Is it hiding? It could be hidden, like in the toolbar. Just check those down, the drop down arrows. Maybe the third line over on the bottom. Yeah. No,
it just says add or remove buttons.
Why don't you check view at the top next to edit and see if it's there? So very limited.
Oh, I think, Penny, I think it's because you're in the perhaps a dietitian basic test account.
Yeah, I am in a dietitian basic test account. Is there another test account that I can use?
I think there's a dietitian 1, if I remember correctly.
Does anyone remember the username that they can put in the chat? Or what I can do is I can just show the form via another user. Sorry, give me 1 second. Okay, logged in as a nurse. Okay, so this is the advanced care planning. This is the power form that I was talking about. So this is usually where the dietitians document on. So if you open this form, it has 2 sections to it. And then the dietitians can document on the advanced care planning and document on various sections.
Are there nutrition specific power forms other than advanced care plan?
There should be. Sorry, let me check. I'm not sure why there's no ad hoc folder for.
That looks like social work.
Nutrition. Maybe because I'm logged in as a nurse, that's why they don't have it. Yep, there's a nutrition screening tool. This is one of the power forms. Yeah, so this is one of the power forms that has content specific to the dietitians. So you can go into this power form and document the nutrition screening of the patient.
Actually, I think just from my familiarity with what I'm seeing on the nutrition screening tool, that's something like an inpatient nurse would fill out, and then that would generate a consult to the dietitian.
I see. So this is not something that outpatient nurses are documenting, dietitians are documenting on.
For home hemo anyway, I would follow and assess every single home hemo patient associated with the program. So I would follow all of them.
Okay. So you don't see yourself charting on this nutrition screening?
Not really. I would just kind of fill out like a form.
Okay. Okay. And I'm not sure why the dietitian login does not have an ad hoc, but I will make sure that we demo more stuff in our next design session. Okay, let me go back to my PowerPoint.
And just to add to, because we're an outpatient program, we don't generally order diets for any patients either.
Mm-hmm. So you're just ordering diet orders for inpatients.
Yes, but
Okay.
we don't see any inpatients here as part of the program. Like the dietitians don't see any inpatients.
Uh-huh. Okay, good to know. So I just wanted to highlight that the nutrition supplements, the entry would continue. So you would have to continue if in case you place the diet orders, the double entry would continue in promise. Okay. So this is how the multi-patient task list looks like. So once you log in, you have that section of multi-patient task list on the top. When you select the multi-patient task list, you see all the patients that are scheduled for yourself to see for that day. And we do have a filter on the top where you can change the criteria. So if you want to change the date to today, or you want to change a date in future, so you can always change the criteria of the date, and your patients list would pop up based on the date you selected. So these are the following. This is a tab for new consoles. So all the new consoles would appear on this tab, and all the following orders would show up on this tab. Okay. So we did have, I guess this is the document or the form that you were talking about. So my question is, does only RDs document on this form, or there are other professions that are documenting on this form as well?
Dietitians and dietetic students would use that.
Okay. Yep, that's all I had for dietitian content. Any questions that you have?
I guess because I don't have too much experience with what the whole system looks like, I would probably come up with more questions once I get to play around with it a little bit more in the future.
Yeah, no worries. You'll have proper training to use Cerner once we near the date of go live.
I just want to add to our kind of encounters with the patients are very similar to maybe what nurses would do. Like we would do an initial assessment, but we'd also talk to patients or email them. So kind of do like virtual encounters with them. So talk to them on the phone or email them, and also see them in person and in clinics. So I hope that gets captured as well.
Yeah, so we do have encounters. We can create a virtual encounter for you, and then you can see your patient virtually or through teleconference or through phone. So we do have encounters for that type of visits as well.
Curious, I guess, Jarik, I guess for future workflow, am I gonna have to send a RD consult for every brand new patient, or will that be something that you just add to your own list?
I expect that I would just add it to my own list, but I don't know. I would be interested to
Yeah,
hear
so
what
that is the workflow for allied. So consults, usually the allied allied health professions place it for themselves and that they appear on their multi-patient task list.
So just to give feedback for what we're doing at St. Paul's right now, when there is a new patient admitted to your unit, there's an email that goes out to everybody. So there's no consult that's needed for any of the allied health. It's just assumed that there's a new patient, you would see them. But in any subsequent interactions, either with nurses or physicians or pharmacists, where we identify that a dietitian consult would be an additional visit would be necessary, that's when we use the RD consult. To notify that the dietitian to see this patient sooner than whenever they may have seen the patient.
Okay, so I just want to point out that consult and the following orders are there in the system for the dietitians to use, but you can always continue with your current workflow of email or verbal communication or however way you're following your patients. Okay. So referrals, but before going to the next topic, I just want to ask the dietitians, do you have any other questions at the moment? Or we're good to go forward? Okay.
We're good, thank you.
Thanks. So I'm going to talk about the referral process. So as we've discussed earlier as well, there's an external referral and there's an internal referral. With external referral, I mean the non-life sites who are just faxing their, who fax their referral form to the home hemo clinic, and when the referral form is faxed, it would appear in the work queue monitor. And what would happen is the clerk can always schedule a pre-assessment appointment from that referral and create an outpatient encounter and then later index that referral into the patient's chart. The HHD nurse would review the referral package, but then they would continue entering into PROMIS, into the PROMIS waitlist. And how internal referrals would happen, there would be a referral to outpatient HHD unit. And then once that order is placed, that order will route to the scheduling queue. And the clerk, once the clerk sees their request list, they'll complete the request, they'll schedule the pre-assessment appointment and register a pre-outpatient encounter for that patient. And for the HHD nurse, once they receive the request, they'll review the patient's chart and they do enter into the PROMIS waitlist. Okay, for demoing this referral process, I'll hand it over to Stephanie to demo it in the system. Steph, take it away.
Perfect. Can you just stop sharing your screen so I can share my screen, please?
Yep, I'll stop now.
Oops. Okay, can everyone see my screen?
Yes.
Perfect. So for everyone that doesn't know, I'm Stephanie Wine. I'm one of the business analysts with the ambulatory design team. I'm just going to quickly go over just the process of the workflow that you'll have for your clinic for scheduling and pre-registering a new patient. So these are going to be referrals for a new patient that have not been to your clinic yet. And I'll go over just quickly what the process is for an external referral and then an internal referral. So for external, and this is also mostly going to be for the clerks, because as I understand in your clinic, the clerks are going to do most of the processing the referrals and the scheduling and the registration. So for external referrals, this is called the work queue monitor. I don't know if you've heard about that before, but basically in Cerner world, all your faxes are going to come through electronically. So this is what it's going to look like when your fax comes through with the referral package for an external referral. So it's coming from somewhere that is not on Cerner. So instead of saying SPH KCC up here, it'll probably say VGH Home HD or something along those lines. So this patient has not been to your clinic yet. So what you will do is you'll look through the referral and you'll probably take out name, PHN, important info like that. And then what we're going to do is we're going to go into the scheduling appointment book or the SHAP book. And we're going to use this appointment tab here. And I should also mention, so you guys will have, I'm using just in the build domain right now, I'm using the Renal Vascular Access Clinic as an example, but you guys will have a book here that you'll bring into your bookshelf, and that'll be the home hemo book. So for booking a patient from an external referral, we're going to go into this appointment tab, and we're going to take the, I would probably search by PHN from that referral. For this demo purpose, I'm just going to use a test patient. So you search for the patient and make sure you have the correct patient. And then they're not going to have an encounter for your clinic because they have not been there yet. So what we're going to do is we're going to add an encounter using this button on the bottom here. And you'll be searching for VGH, of course, but for this demo, I'm going to use St. Paul's. Then it'll do a quick search to the MPI. It's supposed to be quick at least. There we go. Yeah, and then it'll bring up our available conversation window. So this is a registration window. Through this drop down, you're always going to be selecting pre-register outpatient. That's the type of encounter you guys are going to use for the most part in your clinic. Does another search, it brings up the full registration, and we're just going to go straight to encounter information. You guys will be doing the pre-outpatient encounter for the home hemo, and I think you will use nephrology, and you'll put something like HD home assessment.
Steph, sorry to interrupt, can you go back to the patient information, please? I just want to point out the promise flag.
Oh yeah, we can, yeah. So you always, this is super important. You want to make sure that the promise flag is always flagged to yes, because that's going to allow the information to pull into promise. So that's super important. And this is also where you'll add your clinic flag for the home hemo clinic. Yeah, so you have to actually make sure you go into the patient information tab. It'll usually go into encounter tab first. You can also add a provider. That's not a mandatory field, but that's also good information to put in there. And then they're going to ask you which day you want this patient to be booked for. So say you're going to book it next month at 9 a.m. Okay, and let's press complete and see if it wants us to do anything else. Nope, so we've created the encounter. So this patient is now pre-registered as an outpatient to come to the renal VGH home hemo clinic. Press OK. So it's now brought your patient name here, and then you're just going to go through the mandatory fields. So for this demo, I'm just going to use, we're doing vascular. Appointment type. So you're going to have something probably called like along the lines of this, like renal home hemo initial assessment, HD assess. So not all of these fields are mandatory. Just quickly fill in the mandatory fields. If you just press T, you can say, and then for this field, I'm just going to put as per special instructions. You can also pick what priority that someone has specified they want you to book it for. This is a mandatory field, whether or not they need an interpreter. You guys are always going to use in-person/clinic. And then I think that's all the mandatory fields. It's also special, well, not special, but important to note that I don't know if your clinic's gonna be using this field here, but anything you type in here will show up face up for everyone to see in the ambulatory organizer, which is, I don't know if you guys have seen that program yet, but it has a list of your patients coming in for the day for your clinic. So anything you type here, like say the patient had another appointment that day and you want everyone to be aware so they finish up with you, you could be like, patient has another appointment at 11 a.m. So this is just a good field to note for that kind of thing. Then you're going to move the appointment over. So this is just the build domain. So the book looks kind of interesting, but what you would do is basically just take your appointment that you've just created and just drag it over into your book. And here you can edit the duration if you'd like. This is basically what that looks like. We're just going to press OK. It then turns yellow. And then to confirm the appointment, we just have to have one more step. And we're going to press confirm. This is basically showing you just a summary of what you have just booked, and then press OK. So now that you've done that, the patient is actually scheduled into your clinic for their first assessment. So that's what it's going to look like, the workflow for an external referral. So someone that has referred your patient that is not on a Cerner site. When you get a referral coming from a provider that has placed the referral order through Cerner.
Hold on, Steph.
Yeah.
Can you also show the steps to index that referral package to the encounter now?
Oh yeah, sorry. I was totally gonna do that. Thanks.
And can I ask too, this is Linda from Informatics RegSketch.
Oh, hey.
Are they not triaging, or the providers not triaging this? The referrals?
As far as I understand, I don't think they turn down referrals, so they don't have a triage process, and they aren't using that referral encounter at all.
Okay, they're just directly, so anybody that you get a referral for, they're accepting and booking the appointment.
Yes.
Okay.
That was my understanding, at least. Puneet,
Yeah,
can correct me if I'm wrong. Yeah.
No, that's right. Yeah.
Okay, perfect.
And just one other thing, can I just ask as well, do they have a wait list at all?
No, I think they use the wait list through Promise. Correct me if I'm wrong.
That's
Team?
correct. We do use the Promise waitlist.
Okay, perfect. Yeah, so Linda, they have their wait list in Promise.
Okay, but so when they're receiving a new referral, they wouldn't just add that patient to a scheduling request list. So they're actually booking it in scheduling in Cerner, but they might add it to a wait list in Promise, or
Oh
how would that
no,
work?
so Linda, that when the referrals come in for initial assessment, they get processed immediately. So there's no wait list for that. The wait list we're talking about is the wait list for training. So once they've received the patient coming for an initial assessment, they'll get an appointment right away regardless. And then after that, then they get put on a wait list for when they can get a training spot, basically.
Okay, thank you.
Perfect. Thanks, Flo. Yes, so this is the referral package that is now still in our fax queue. And what we want to do now that we've pre-registered that patient and we've created an encounter, we actually want to index this referral package under that encounter. So what we're going to do is we're going to double click on the referral package. And this kind of window will pop up. And under the document type, I think we have one called referral package. And we'll select that. And then we want to make sure we change the status.
The patient first.
Oh, okay.
The patient search.
Okay, I didn't know I had to do that first. Thanks, Flo.
You're welcome.
So CSC test, SPHHD test. Yeah, so we're going to search for the patient, and this is so Workey Monitor is going to know which encounter we want to index this document to. So as we can see here, right, I think I just selected, I must have just selected 10D, which is fine. This is just for an example. So you'll find the encounter for home hemo, basically in real life. There we go. And then what I was actually looking for was the box that lets me select complete. It usually says available. Oh, status, there we go. So you want to make sure the status is changed to complete. And then I don't know if it's going to let me do this in the training domain, but you want to scan it under scan document. Perfect. So it did work.
Oh,
and those are
it's the last field that you want. Yeah.
Scroll down. It's the performing provider field.
Okay. There we go. Perfect. And those are all the mandatory fields. And once we have all of this filled out, if we just hit root, it's going.
You also want to make sure that the date of service is the date on the referral itself.
Oh, okay. Sorry, I didn't know that was part of the workflow.
Yeah, the document date should be the date of the referral, the date on the referral.
Oh, okay.
But that's all in the training material.
Yeah, I was going to say they will have their specific training as well. Here, sorry, which field were you? This one?
Yes, correct.
Okay, so just make sure that I guess the date of service has the appropriate date here as well. All right. Okay, so that is how we would schedule and pre-register an external referral. So for internal referrals, we don't have to use Workey Monitor at all. You'll just open your scheduling appointment book and you'll go to the request list queue, which is this little magnifying glass right here at the top left. For demonstration purposes, it says renal vascular access, but obviously yours will say home hemo. You'll press find. And so what this is showing you here, and the clerks will be very familiar with this. So any orders that the provider has entered that are set up to route to your scheduling list will all show up here, so you can book the appointment. So we're gonna just pick one here. And if you right click, we're gonna complete the request. This is just showing a summary of other appointments the patient may have. Press OK. It brings up this other box here. We're just gonna press OK. So now you can see that your patient has shown up here in the WIP, we like to call it, work in progress box. And from here, what we're going to do is we're going to drag the appointment into a slot, just as we did with the other one. The same box comes, press OK. This is just saying, I think this might have something to do with the build domain. We're just going to override this again. This probably won't happen in real time for you, and there we are. So now, as you can see, it's turned yellow again. We're going to hit confirm. Summary of the appointment, perfect. Press OK, and there we go. So we've actually booked this appointment to the renal vascular access encounter. I'm just wondering, because it didn't let me create the new encounter. Hold on.
Hi, Stephanie, this is Dan. Is there a way you can navigate through what you're clicking just a little bit slower so we can see where you're pressing?
Oh, yeah. Sorry, Dan. I was just kind of doing a very quick, because I think you guys are going to go dive deeply into this in the scheduling sessions.
Yeah, I have a session on Monday and I can go through this in more detail. But Stephanie, the reason you didn't get asked for an encounter at confirm is because you selected it or you created it at the beginning of the process. But you're right, we usually do select the encounter on confirm.
Okay. All right. Well, I think, is that kind of what you wanted, Puneet? Just kind of a quick workflow
Perfect.
demonstration?
That's all I wanted.
Does anyone
Yeah.
have any other questions? Sorry, Dan, I kind of flew through that.
Yeah, it's just, I think sometimes it's a little harder when you're just rushing through it like that. It doesn't even provide us an idea of what kind of questions to ask, right? We just see its cursor going, flying through, and then just being asked, do you have any questions? Like, well, we didn't see much. So
Okay.
I guess that was the point I was trying to make.
No, that's totally good to know. Definitely take that in consideration for next time. All right. Thanks, everyone.
Okay. Thank you, Steph. I'll quickly share my screen again.
Just one sec. There we go.
Okay. So the next piece that I have is for the nurses. But I know my acute team members have to drop, so I'm gonna quickly give the floor to them. Vivian, Irvin, are you on the line? Do you want to talk about the log?
Yeah,
Or...
it's Irvin. I'll talk about the log.
Okay. Sorry, just a second. Yep, take it away. I'll just stop sharing my screen.
Sure, thanks, Puneet.
No worries.
Okay. You guys can see my screen?
Yes.
Okay, so there's a lot of information here. So I figure I'll just zoom in. I'm sorry, my name is Irvin. I'm from the acute care team with Vivi also on the line. What we're doing now is looking at your forms, reviewing your forms that you guys use, and then seeing if there's existing information or already built stuff in the system that can be leveraged, and confirming and verifying how certain areas of this forms are used as well. So we'll start off with your NX home log, and I'll zoom into certain areas and walk and talk through this form one section at a time. Okay, I'll start with the top left-hand side here. So in the pre and post-dialysis vital signs, we have that already in the system, similar for goal weight as well. So I'll move down here where the symptoms are. So first question, I guess, is do you guys for this symptoms, are these for pre or for post screening?
Both. So if you see that there's a repetition between dizziness and dizziness, right? The left side is for pre and the right side is for post.
Gotcha. I was wondering why there's two dizziness. I figured it was a typo. Okay, so all the ones in green, highlighted in green here, are the ones that we have in both pre and post. So shortness of breath, swelling, dizziness will be in the pre here. Dizziness will also be in a post here, down here, what's is in the system. Headache is also in both pre and post. Nausea and cramping. For nausea, it was a requirement in post, in HD, so that has been taken care of. We will be adding nausea and vomiting as the two new symptoms for the post HD screening. Cramping is also available for post. So I think we've covered all of the symptoms. Is that correct? I can give you guys a chance to take a look at the list.
I mean, I think that's fine if we're following what the HC side has, which probably they list more of the screening tools, and that's totally fine.
Yeah, they have everything they need. They only added nausea and vomiting, but everything else is fine for them. Just verifying for this highlighted section here, for last off weight, is that the same as post HD weight?
That's the post HD weight from the previous run.
From the previous run. So we have that here under post hemodialysis measurements.
So I think that's different. That's post HD weight from the
current one.
Current run. That's correct. So I mean, just so you know, I mean this is for a patient to be taking home with them. So that's why we asked them to put the last off weight.
Okay, so they take this home.
Yeah.
Oh,
I mean,
okay.
there will be occasions where a patient may come here for a run, and let's say maybe they're not feeling very well, so we'll be the ones doing all the monitoring. So that's when I do see us putting all this information in.
Okay, essentially top to bottom is all brought home. Patients fill it out for the most part. Okay.
And I believe Emmy and Max are there so that you guys can add on to this too.
Sorry, can I add a comment? There actually is a last post HD weight DTA already.
Okay.
So you can use that.
Okay, thank you. So let me just also writing notes. And then future state Alberto, I guess they bring it back to you guys and then you would document it in Cerner?
No, they keep it. So it's their own records.
Oh, okay, so this is not an official legal document that clinicians would be using to document or to keep on file.
This is Amy. I just patient to bring it in if we see them in the clinic. They just want so we can go through the blood pressure and weight and that kind of stuff. After the clinic, usually they just discard it, so they don't keep it, and then they start again. So
okay, yeah. So this is like a guide.
Just a record for them so they have a up to date like a list of a blood pressure how they go for the last month or two. Yeah.
Okay.
So for the pharmacists as well, so they can see the trend of the blood pressure, so and weight, that kind of stuff, any symptom that they have and the date that happened.
So I hear a lot of different clinicians referring to this for information. Is that correct?
Mm-hmm.
So I'm thinking future state, since you guys wouldn't be documenting on Cerner for this information, everyone will still keep on using the paper.
Hey, Irvin, I think this was just...
for the patient. Yeah, for the patient, and so they have a record.
Hey, Irvin, I think this is kind of what we were talking about earlier when the providers were on, around where we'll keep, like the patients will continue to document and keep track of their own HD log.
Okay.
And then there was just a discussion around whether or not there would be times that a nurse would enter this information if the patient was on site, or whether or not in the transition period, patients from East Van and Richmond would be entering this stuff into Cerner. So I think that was around this log.
Okay. So operational, that's still yet to be decided what they want to do.
So I think for us, our goal, we just want to make sure like all the pertinent information, if we were to ever start documenting in Cerner, that we have those fields that we need.
Yeah, for sure. Okay, I'll just keep going. It's very helpful to know how this form is being used. Okay, so moving down at the bottom section, I'll just zoom in one more time. Moving down here, we have vital signs, we have the time, BP, and pulse. I just wanted to clarify what dialysate here under the rates column here means. Is it the same as the one that I have found here for these different dialysate additives?
So no, it'd be a little different, just like I think Dr. Copeland mentioned a while ago, just because the prescription for this machine, which is the NX, that's the next stage, and it's going to be a little different. Same thing when we're logging, we're monitoring like the treatment for this machine. So if you've seen the top, which says rates and volumes, so this machine has technically two toggles, two screens where you can switch between. So the rates screen will give you dialysate, your UF and blood flow on an hourly basis, and the volume screen is like a total. That's why you see a duplicate of dialysate and UF. So the rate screen gives you dialysate and UF on an hourly basis, and the volumes and the dialysate and UF under the volumes gives you the total for the treatment.
Okay, so seeing it's a rate, what is the unit of measurement? What sort of, so it will be a numerical value with a unit of measurement? Is that what it's written here?
Yes.
Okay.
Liters per hour. Liters per hour.
Liters per hour.
Yeah.
If you look at the right-hand side here, what is currently in the system, highlighted in green are the ones sort of similar to these sections here on the left-hand side. Is there anything here that it sounds similar to that dialysate rate? Which I don't think so, but
no. I doubt it, because the current one wouldn't have it.
Okay.
From what I see, no.
Okay. Ultrafiltration rate, UF, that will be this one right here?
Yes.
Okay.
But that will be the one, yeah, correct. So the ultrafiltration rate will be the one that's shown on the left side where it says under rates, but not the one that says under volumes.
Okay, I hear you. Okay, so UF rate, blood flow here, is it this blood flow rate here as well?
Yep.
Okay, great. So we also do not have a dialysate volume. Is that correct?
Yeah, so it'll be the dialysate volume and dialysate rate.
And to just to line up with the other measurements, they will be in mils.
That is liters per hour, right?
Yes, correct. Liters per hour.
Liters per hour. Same for the rate. Sorry, you said the rate as well?
Yes.
Okay. Well, I guess if it's volume, then it will be just liters, right? Or am I mistaken?
Sorry, repeat that?
Sorry, if it's a volume, then it will just be liters, right? Not liters per hour. Just to confirm.
Yes, you're right.
Okay.
For the total, the volume, yeah, the
volume is just liters, yeah. So we covered. Is the UF here for volume the same as ultrafiltration goal?
I'm not too sure how the ultrafiltration goal is being used. I'm guessing that's for the total. The volumes column, which is UF, that's kind of how much has been taken off so far.
How much is taken out?
So I don't know if it's the part.
Oh, there's the
ultrafiltration volume removed. Possibly it could be that one. Yeah,
It
because
will
that's
be
what
that
we do for that column there.
So that's fine. For the pressures, we have the venous pressure up here as well. I know it doesn't say arterial, but arterial is here as well. So I just want to confirm what effluent or access pressure means.
Yeah, so for this machine, there's three pressures they follow. So venous, they do arterial. That's kind of so under comes this effluent / access. The access is kind of seen as the arterial pressure, but the effluent is another pressure on its own. So effluent pressure would have to be added.
Okay, and you use both effluent and
arterial. So current right now they're charting both values in that one square. Effluent pressure and access pressure, which is also our arterial pressure.
So right now in this form, how do you identify if the number that you write down is effluent or access? Do you just circle it?
The top number will be the effluent pressure and the bottom number will be the access pressure.
Okay.
It's just, yeah, I don't know why it says access. I don't know why it's been there for a long time, but it should be arterial.
Yeah, it should be arterial pressure next.
So arterial. And if we do add an effluent pressure, it being on a different line than arterial, is that
You can put it right below the venous pressure, like right beside arterial venous pressure, right below it. Yeah.
and it doesn't have to be like over like how you write
No,
it.
no. I think that makes it too confusing.
Second. So just going back to the dialysis rate. Here, do you identify which? So it's nothing to. It doesn't point out to any specific additive like the ones I have at the bottom, right?
No, that would be the additive portion would be that top right part of the big box you have there. Most likely would be somewhere up there. The top right.
Top right. Like
Yeah,
here?
within there. Yeah, because that's all part of
the water test section. Okay.
Yeah.
I'm just being mindful of these changes, of these potential changes that will impact also other live sites as well, such as St. Paul's. So I was hoping one of St. Paul's SMEs are on the line as well. Because if, for example, just adding the effluent pressure will also affect them.
Well, if anything, it'd be a St. Paul's
With the same-
HD SME, but I guess the other St. Paul's SMEs, they use the same machine as us for home
Yeah.
hemo at least.
Okay.
But if you do probably bring in the HD SMEs, they might get confused.
Okay.
All right,
So home hemo likely.
I just noticed Alina's here from St. Paul's. I don't know, Alina, if you want to comment on these changes that we're adding. Because the intra-hemodialysis IV section is used by HD.
Unfortunately, I don't, as you guys, I don't understand I don't do home hemo, so I can't comment on it. Max and Emmy will be the ones who can.
The machine is the same. The next stage machine is exactly the same as what VGH and St. Paul's using for the next stage. Yeah, and also the Gambro as well. So, yeah, the form. Yeah, we use exactly the same form. Anyway.
Okay. So what I'm hearing. Okay, what I'm hearing is HD.
Yeah, we're good.
Okay. Going around and back to the top here. There is this calculation here from pre-dialysis down to total weight, and on the right-hand side is what it currently looks like with a calculator. So it's just verifying. So pre-dialysis weight, we have the pre-HD weight here, goal weight, similarly goal weight, and then just confirming weight to lose is similar to target net fluid removal.
Yep.
Yeah.
Okay, great. Saline rinse back. So we have rinse back. Other intake will include both PO and IV fluids. And then total weight to lose will be the total.
Yeah.
Okay.
Okay. And here is what is considered in the calculator here. Okay, so no problems there. So you mentioned this chlorine water test. Is this something that I guess everything in this document you said is I guess kept by the patient and discarded after. But in the future, do you think if operationally the team decides to chart this on Cerner, would you need this information as well in the top right-hand corner?
Chlorine test, I think, will be needed. We do
Everything
it.
in this box here?
Yeah.
Okay. And this box is different from the other CV log section?
Yeah, it is.
Okay. Lactate, is that lactate, is that the blood work lactate?
I know because in the other CV form that you have, they use bicarb. And this machine uses lactate.
Okay.
For their mixtures, if that makes sense. So it'd be part of the prescription. How about that?
Okay. Is this currently in promise, this information?
Yes.
Yeah.
All right, Alberto, you said this is captured in the prescription. So are nurses transcribing the prescription here, or is this the actual prescription from the provider?
So yeah, this would be the prescription that the provider has originally instilled for their treatment. And for them, they should just be constantly, well, ask them to constantly just repeat writing it over and over again during each treatment.
Okay, so I think moving forward, this is only going to be captured in the prescription power form then, because we don't build out DTAs for nurses to transcribe prescriptions, because then there will be multiple places for the source of truth. Unless there are cases where you're required to actually document what was done during the treatment and then document the changes as they happen.
Well, that's fine. Fair enough. I guess, yeah, as long as there is going to be that next stage prescription on there, yeah.
Can I just ask a quick clarifying question? Irvin, can you just scroll down a little bit to the dialysate section? Just want to confirm if the dialysate here is different from additive. I think it's just further down. Can you just scroll further down?
Further down. Oh yeah, Alberto said it's different.
Yes, it is.
Oh, it's different. Okay.
Yeah.
Okay, so I think that covers the NX home log.
And I guess I just to add too is so that top right corner. I mean, yes, there's that portion that's dialysate, KCA, right? So yeah, that would be the prescription, like Vivi was saying. But the bottom portion of that box is actually in terms of the physical equipment that is being used: the PFSN number, pack lot number, stack lot number.
So only potassium, calcium lactate are covered from the prescription.
Yeah.
Okay.
And same with the temp setting.
Under prescription as well. Okay. So bottom, yeah, very okay.
And the chloramine water testing, we still need that.
And that would just be like a simple yes or no.
Yes.
Yes.
And sorry, is this captured as part of the machine parameters? I'm just trying to figure out what section would be appropriate to have this information.
So I'll pull up the machine parameters here. So you know. So over here we have the HD machine setup. Does that fall under this?
Yeah, it would be under setup, because if you got the machine number and machine type, then yeah, most likely you will put it there and under the machine setup.
Okay. Is there anything that is already in the system here? Does machine number make sense to you, Alberto?
Hold on a sec. Let me just grab it.
Sorry, Urban, are you able to open it up like side by side?
Yeah, okay. Let me just, there we go. Sorry, Alberto.
Oh, good, don't worry.
There we go.
I'm thinking the machine type, we'll have to add the home hemodialysis machines to that drop-down list, right? Only 3 available right now.
Yeah.
Can you send us the names of the machines?
Sure.
Thank you.
Okay.
Yeah, but all the other points where it's talking about new batch, expiry time, PFSN, cycler, no, those will not be captured there if we're thinking about the other side, the HC side.
Okay. Is there, it's probably too, I don't know if you would have an answer, but is
there one that we can reuse?
No, where would you ideally place this information in this section, given the options that we have here? Or Vivi would just be conditional logic?
That's what I'm thinking, is that if we add the machines to the machine type, when you select the home hemo machines,
right,
the appropriate fields will pop up.
Okay.
So that there's no impact to the live sites, or minimal impact to the live sites.
Yeah, I was just going to say it's probably just cleaner if it's that way. Then you don't have a long list of
Okay.
DTAs.
If we do bring up that list, Alberto, is there a specific order that you wanted in their
No specific order.
Okay. Okay. So we'll just get that machine name from you and everything else that comes along with it.
Sure.
Okay. there anything else that is out of the ordinary or that stands out in this form? Otherwise, I'll move on to the CV log.
I just had a quick question though. With the dialysate rate volume, do you have a preference for sequencing? If
How
we're
so?
gonna add, like, do you want dialysate rate to be above ultrafiltration rate and blood flow rate? Like, does it matter to you?
Sure, below blood flow rate, I guess, before the ultrafiltration goal and stuff. You can put dialysate rate and dialysate volume. ME max. I don't know if you guys have any preference.
Doesn't really matter. I don't think.
I thought I'd check just in case there was some, preference.
Okay, sounds like you're pretty open to leave it to our discretion, but if you said below blood flow rate for the ultrafiltration, okay, for the dialysate, okay, I'll add that to my notes. And then I almost forgot this, the second page of this form. So this looks like a form really just like for patients to keep track, like a checklist, like a reminder for them. Since we can't really add checklists into the system, I don't think even with the discussion earlier about potentially adding this to Cerner, all of this first page being documented in Cerner, I don't know if this is something that this has to be captured on Cerner as well in some form or another, whether that's a legal form or you just want to keep it on paper since it's going to be discarded anyway.
Yeah, that's correct. That's mostly just for patients to go over the checklist to make sure that everything's set up appropriately before they start the treatment. So if we're considering for us to be charting this portion of dialysis, we wouldn't really be taking that stuff off.
Okay. At the bottom here, there's comments. Do you take anything that you would potentially chart anything on Cerner in the future if that's a decision we go for?
Not that I can think of, unless Emmy or Max have anything else to add.
No, I think that's more for the patient as well.
Okay. So maybe we can keep this on paper.
Yep, I think so.
Okay. All right. I'm going to move to the CV log. So really, it's mostly the same. Just a few things different from at the bottom here. I'm guessing on the same questions from my annex form is on the left-hand side of pre-screening, the right-hand side of post-screening for the symptoms, sorry?
Correct.
Okay, great. Zoom in. So we have, starting with the blood flow, we have blood flow rate. Is this the rate as well? It doesn't really specify.
Yes, yes, it is.
Okay, venous pressure, we got that. Arterial pressure, we have that too. Just wondering what ACC heparin is, and it's the same as this heparin column here?
So accumulated heparin, the amount of heparin that's gone through. So I'm sure HC already has something like that.
Accumulated heparin. So would heparin infused / volume be?
Oh, there we go. Yes.
And then next one is accumulated ultrafiltration, which is
Ultrafiltration volume removed.
It's also volume removed?
Yeah.
Okay. The next one, ultrafiltration rate, I'm guessing, for UFR. Or sorry, removed. Oh, wait, no, sorry, you just said removed.
Right. Just a rate.
Rate, okay.
Well, yeah, hold on. The UFR is the ultrafiltration rate. The accumulated ultrafiltration is the ultrafiltration volume removed.
Moved.
Okay. So accumulated ultrafiltration is the rate.
Accumulated ultrafiltration, just to explain, is how much fluid has been taken off so far. So that will be under ultrafiltration volume removed.
Okay.
Right, that's what the HC is being used for.
Okay.
I would think so. And then UFR is the rate, so that would be under ultrafiltration rate, the one that's not highlighted in green.
See it. Okay. Thank you. The next one, sorry, what is the heparin/syringe in this column?
That's how much heparin has been put into the syringe primarily. I mean, I don't know if you teach patients to use that one or not.
Is it
I
something?
do ask them to look at how much remaining in the syringe.
How much is remaining in the syringe?
Yeah, that's what I use them for.
Yeah, I don't think current state even HT does that. So, I mean,
This is something
because
you
I
need
mean,
to
yeah, I mean, for us, like if we're the ones charting on this, would we want to write how much heparin is left in the syringe?
Would you care more about what is infused then? Like
Correct.
And so is there a potential, do you think you will continue to document on this in the future?
Yeah, I personally think as a nurse, I wouldn't want to document that future.
You would
I mean,
not want to.
in the paper, I will leave it since Emmy's using this still for her patients. But I would think, like, if we're talking about the Cerner for nursing charting on this, I wouldn't think the heparin/syringe would be needed to transfer it over to Cerner.
Clinically, there is no indication or significance to charting this in the future.
I personally don't think so. Unless, I mean, if you want to put it in, I'm totally okay with it.
No, I think it's more for the patient, so they have a scan on the syringe, make sure they still have heparin in there. For
I think people are using it as a double check, right?
Yeah,
Just
so fair
make
enough.
sure it's confused compared
For
to
nurses, yeah, I think.
Perfect. So in consideration to that, I guess it's only just be left in paper.
It sounds like it's more for the patient to know.
Yep.
Okay. So what I'm hearing is we
do not need to transfer it over to Cerner.
We'll leave this out. Okay. And lastly, TMP is transmembrane pressure, highlighted down here as well.
Correct.
Okay. Okay. Oh, just one more thing. Accumulated volume. Is there anything here that speaks to that one here? And what does that mean as well? Just wondering as well.
I would think they would have it at the for HT as well. This is the amount of I guess liters of blood that's gone through the machine.
Okay, let me take a
Oh,
look.
we do have a liters processed.
There, yeah, that's the one. Liters processed.
That one's captured under post, I believe.
Post. Here we go.
Yeah, all that bottom part, the total fluid dielectric clearance and accumulated volume would be under post.
Okay. And in the future, once, if and when the site decides to document this on Cerner, would you need to identify which one is a CV documentation, which one is an NX documentation? Or will the list of machine capture that?
I guess if you're going to do that conditioning for the machine setup, it should be fine. But the bottom portion for the monitoring, I don't know if that's going to be conditioned or not too. So like it'll pop up because the only difference really when you're doing monitoring, aside from that, is really the dialysate rate and dialysate volume.
Right. So
I think the question is, do we need to have unique fields to capture NX versus
oh, I see what you mean.
Yeah.
I don't think so. No.
Okay, great.
Okay. And there's the machines for each NX and HSR and CV are different, right? The names?
Yes.
Okay. So so once you've put in that the machine name here, it will give that. So we'll just keep documenting all the way down and you'll know it's from that machine type.
Okay.
Okay. So same calculation here. And then for this, is there, okay, so just clarifying everything else from additives. Can you tell me the difference from this to the other one?
The additives is the thing that you were
Yeah.
that you were mentioning earlier. The one you did show the additives before. So additives, there are no additives from the other one, but you will see additives in the current one if we're following those with the HD one.
Okay.
Where they use the phosphate enema and stuff. Do you recall that part?
I personally don't.
There is a portion of it in current
Yeah,
Cerner.
we have sodium phosphate and
okay.
calcium chloride.
So yeah, that's it.
So everything seems, so we only need to add temperature. Sorry, this will be the power formula, right?
So the dialysate portion, everything dialysate and down should be captured in the prescription.
Okay. I hear
Aside
you.
from the additives portion, I guess you have another DTA thing area for. But the top part is a bit different. The chlorine water test is for us to check the water of the machine. Same with the dialogues. And Emmy, I don't know if we need the venous pressure or the dialogues peroxide test. What do you think?
I don't think we need the venous pressure test anymore. Like the machine do it automatically now.
Yeah, correct.
The 95, the AK95 that we need to do it manually, but not now. Yeah.
So
what about the dialogue? I mean, if we're having chlorine water, chlorine in the next stage, then should we have the chlorine water tests for this one as well? I mean, oh, sorry. I guess you're adding the chlorine portion anyways, right? For the next stage, right?
Yeah, it would be the same field.
Yeah, perfect. So that's
I think the
fine.
dialogues, yeah, once a month we do it. So we should, in case.
So we should keep the dialogues?
Yeah, I think the dialogues is good. But
And
the
so-
venous pressure, you don't really need it.
And so if you had just selected the machine for CV,
Yeah.
it would bring up another line that asks chlorine water test and then yes or no. Is that what you're thinking of?
Pretty much the chlorine water test to make sure that the water quality that we're using is up to par before a patient starts their treatment.
Okay, so what does it mean when you click on this box that it
has been done?
Has been done.
It's been checked.
Okay.
Yeah.
So is it appropriate to have the responses when it does come up on this list for a yes or no?
Oh,
Say
yeah.
if the text on the left hand side is chlorine water test, and then the responses will be like yes or no.
Yes, correct.
Sorry, just wondering if chlorine water test completed and then the response being yes or no would make more sense.
Mm-hmm.
Sure.
Yeah.
Yeah.
And then you want to keep dialogues, right?
Yes, for that, I mean, I don't know if we should put dialogues.
Yeah, just like residual testing performance.
So
After
similarly-
bleaching, that other machine, we do dialogues anyway.
Okay, so dialogues water test completed, yes and no, and we will leave out venous pressure tests.
We don't need that venous
Don't
pressure
need that,
test.
okay.
Yeah.
There's just a question in the chat to confirm that the dialysis machines are the next stage in AK96. Are there any others?
Yeah, 96-98.
Okay, thanks.
And let's see.
Sorry, did you say that there was a dash between K and
96 and 98.
Okay, so there should be a dash.
96 and 98.
Okay, so no
So
space.
no dash. Yeah, two separate machines.
Two different machines.
Sorry, I meant like this.
Yes, AK98.
Okay.
For these new responses and data that we'll be adding to the system, is this something you need to be captured on a report?
Do they capture for HD?
Yes, if you need to pull up a report in Cerner, you're able to capture, generate reports for your clinic.
What's the reason why HD would do it?
So it's the run logs For HD, they can print run logs based on all this information entered. And then like when they transfer patients, they just print the last 3 run logs. But for home hemo, you guys probably wouldn't really need it because the patients are logging their own.
Okay, yeah,
And
no
then
need
if
then.
you guys were to enter it in Cerner, then you don't really need to print it back out for the patient either, I'm assuming.
Okay.
Can I just, oh, sorry, go ahead, finish that thought.
Oh no, I was just saying no need then, I guess.
Can I just scroll back up if you can, Irvin? I just want to confirm what dialyzer is. Is that
Dialyzer, is it under
sorry,
CV?
Yes, it's in the CV. Yeah, it's just under the additives. Is that something that's captured in the prescription?
Yes.
Okay.
Yeah.
Okay.
And just so you're aware also, there are the 296, 98, but they will be under CV. And then next stage is under the NX, just to clarify that.
Okay. I don't know if there's anything else I missed, VV, but that's covers, I think, most, if not all.
Yeah, I think as we go through our DCW work, we may have additional just like detailed questions. Would it be okay if we send you those questions via email?
Yep.
Oh, I think I should show the transonic changes. I think it's beneficial.
Yeah.
Okay, so Alberto and Emmy, I'll show you the requirements from the transonic side of things. In Cerner, we call it hemodialysis flow monitoring. That way it's applicable to a lot of areas. So for indications, I also show my screen side by side. Just go through here. I guess it's easier to show you. So for indications, these are the list of indications. What we had gathered from, I think that was Vascular Access Clinic, is that they wanted to add post-fistulogram on top of what's existing on this list. That's the only change for indication. And then depending on the access type that the user selects, if it's an AV fistula, left or right, or arteriovenous graft as well, it will bring up conditional logic DTAs as well. So for example, if I decide to do AV fistula here, it will give you this delivered flow QB and access flow 1 and 2. And then similar to graph, no changes there. If we do CVC, left or right, it will change that to line reverse and delivered flow QB. And is there anything else that I may have missed?
Curious, I guess, Flo, I guess future state for HC, are they going to be doing transonics on Cerner and Promise?
Yes, it's going to be both still.
Okay.
Okay.
You'll actually see a DTA at the bottom where it says documented and promise yes and no as a reminder.
Oh,
okay.
It's right there.
Okay.
Awesome. That's it for me. Thanks everyone. I'll stop sharing the screen.
Sorry, Alberto and Emmy, just wanted to clarify for the machine names. I just confirmed with the ambulatory team that for the provider prescription, they're going with the naming convention without a space. So just AK 96 and 98. So we'll just follow the same naming convention for
Shouldn't be a problem.
Perfect.
Okay. Thank you, Vivi. Thank you, Arvin, for that. I view detailed documentation changes. I'll quickly share my screen again. Sorry, give me 1 second. Okay, so coming back to the nurses piece, so the next presentation is I'm going to be presenting how the nursing workflow would look like in the future state. Arrival and check-in. So the first question I had, how many beds and chairs are you guys currently assigning to the home hemo patients when they're coming in for training?
8.
8. Okay. Thanks for that info. So there
Which
are
also,
two.
sorry, which also can be shared between, there are 2 beds that are sometimes shared by PD.
Okay, so that means at the moment there can be 6 home hemo and 2 PD patients that are being treated.
Well, sorry, to be exact, it's like, so there's 8 stations for possible HD, but
Mhm.
2 of those stations also can be used for PD.
Okay. Okay.
So I don't know what your logistics are in terms of like mapping out a unit.
Yeah. So yeah, that the number of beds and chairs was just what we wanted because we need to assign a location, the ambulatory organizer, for you to assign a bed to the patient when you check in a patient.
Okay, then 8.
Yeah, okay. So there are 2 ways, and I'm gonna dive it into the system and show you the ambulatory piece, but there are 2 ways to check in a patient. One way is the clerk can check in a patient via chat book and assign the patient to the bed from the chat book application. And then the other way is from the ambulatory organizer, the nurses can check in and assign a bed and chair to the patient. There's also COVID screening. So can I just ask, who does the COVID screening? Is it the clerks or the nurses that are screening the patient?
Nursing.
Nurses, okay. To know. So this is how the view for the ambulatory organizer would look like. It has various components to it, and all these components are being pulled in when the patient has been scheduled from Chatbook. So the time when the patient's appointment is, the duration of the patient, the duration of the treatment, the details of when the patient is coming in. And usually there is a confirmed button that says that the appointment for that patient is confirmed. And when the patient comes in, you click on this confirmed section and you see a drop down of various workflows. So if you want to check in a patient, you'll select that check in and you'll check in the patient. If a patient does not show up, you can always go in and say no show for the patient and follow the no show workflow. So this is the COVID screening power form that we have in the system. So there are 2 places where COVID screening can be documented. One way is that you can use the COVID screening power form that is available for the nurses and for the clerks to document on. And there's also a section in iView where COVID screening parameters can be documented. So in the system, I'm just going to show you what the ambulatory workflow would look like. So same as the providers, the outpatient HHD nurses would have the dialysis management M page to view the HHD prescription. Those components would be the components that the providers M page would have would be similar for the nurses as well. And then we would also review orders profile, power plans, labs and meds in the system. Okay. Let me quickly dive into the system now. Can everybody see my screen?
Yep,
yes.
We can see it.
Okay. Thanks. So this is the landing page when a nurse logs into Cerner. The nurses would also have the message center that we discussed about. So same functionality, it would have results, messages, general messages, reminders, saved documents, the same functionality. This is pretty standard across professions. So this is the message center for the nurses. This would be the ambulatory organizer view. So it has different components to it. As I discussed, this would have the time, the duration, the patient's name, the details of the procedure, the status of the patient, and there's a little section of notes. So for example, if a patient has arrived and you want to add a note that the patient is waiting in the waiting room, you can just add a note and just save it. There's also a there's also functionality to select the patients that you want to view. So this is the resource group that is available on the ambulatory organizer. So usually what you would do is you would go ahead and select VGH HHD all resource group so that all patients scheduled for that day would appear on the ambulatory organizer. But you can always go ahead and see and select other facilities to see their patients for the day. This is the calendar view. So if you select this, you can go back in the future. You can go back in the past or forward in the future and see what patients are scheduled in for a future date or a back date. So you can see for February 10, 2022, there was no patient scheduled. So this list is null. Okay, so I'm gonna quickly go into the patient chart. So this is my demo patient for today. So just want to make sure you select the right patient and the right encounter. So for the purpose of this demo, I'm selecting the recurring encounter on the SPH HD unit. Okay. So this is the landing page when you go into the patient's chart. It has the ambulatory workflow M page. It has the dialysis management M page for the nurses, which is pretty much similar to what the providers have. And it has the patient banner bar, same thing. All these information is being pulled from when the patient was registered. The process deletes the disease, the isolation alert. So if they were documented while registering the patient, it would show up in the banner bar. But the nurses can always go in and document a process alert from PowerChart. And once you document the process alert, it would show up in the patient banner bar. This is the location. For you guys, it would say VGH HD independent nocturnal. Okay, so going to the dialysis management M page, this is a customizable M page, so you can select which subsections you want to view when you're viewing the patient's chart. The same workflow, there's a section of components on the top right corner, and you can select and deselect which components you want or not want to view for that patient. So for dialysis prescriptions, we have a bunch of places where the nurses can view the dialysis prescriptions. First is the M page. So whenever the provider documents or updates the prescription, you can just go into this dialysis prescription section and see the updated prescription. This is one way for reviewing the prescription. The other way is results review. So this is another functionality where we have a comprehensive and a consolidated view of the patient's chart. So for example, if you want to see the dialysis prescription, you go into this flow sheet tab and you say dialysis view. So it's going to give you whatever dialysis parameters have been documented in the patient's chart. So currently we have levels to this view. So for example, you want to see the dialysis view, and since we have HD prescription documented at the moment, it just says HD prescription. But if there's any other forms or any other pre-assessment documented, it's going to give you a level to select that as well. So for example, if you've documented in iView, it's going to give all those sections where you can just filter out that section and see what's being documented. Okay, and the third part where you can see the prescription is Forms Browser. So this is another section where the dialysis prescription, or if there's another form that was documented by any clinician, you can find that information in here. It has a filter, so you can sort by forms. And if you sort by forms, you can see hemodialysis in here. And if you click on this, you'll see the the dialysis prescription, the latest dialysis prescription that was documented by the provider. Okay. But usually what we recommend is going into the dialysis management M page or going into the results review to see the dialysis prescription. So moving forward, this dialysis management M page has different sections. It has pre, intra, post vitals. It has histories. It has your vascular access monitoring information. It has access care planning and goals. So if any allergies have been documented for the patient, if there's any histories, it's gonna show up in the dialysis management M page. There is a section for team communications that I want to point out. So this is where you can communicate with the clinicians, or you can leave a note for the clinician. So if in case they log into the patient's chart, and if they go into team communication, they're going to see a note that's being entered by you. So let's say dressing change. And if you say available to all and save, so this note is going to appear on the clinician's team, on every clinician's team communication section when they go into the patient's chart and go into this section. Okay. Yep, it has various components to it, and you can always customize it based on your need. So if we go into under the ambulatory workflow, there are sections where you can document a nursing narrative note. So say if you wanna add a clinical note for the provider or for any clinicians, you can always go in and just free text and type a note. I'm just gonna say dressing change again, just for the purpose of this demo, and I'm gonna say sign and submit. So if you want to forward your note to the provider so that it comes under documents, under their document section, and under message center, and under the document section of the power chart, you can just forward this note to the provider. Okay, I'm just gonna sign. So this is a way that you can document a nursing narrative note. And if you go under documentation, just gonna refresh. And if you go under documentation, you can always find your nursing narrative note in here. So this is a place, this is a section under power chart where all documents would appear. So as we were discussing earlier, if a scanned document has been indexed into a patient's chart, this is where you would see that scanned document. Okay. Workflow, everything's captured. So orders. This is a section where you'll see the power plans that has been placed by the provider, and you can action on it. So based on the power plans that the provider would place, it would appear under this section. So at the moment I have placed a PD training power plan for this patient. So if an HHD power plan, a training power plan, or an admission power plan has been placed for that patient, you would see those power plans under this section. There's also a categorized way to see the order. So one way is to look at the power plans and go in and view the laboratory or the medications, but there's another way that they're categorized under the child orders. So if you want to just look at the medication or medication orders that are in place for that patient, you can just go under the medications child orders, and you can see a consolidated and a comprehensive view of the medications that are ordered for the patient. You can see the laboratory tests. There's section for pretty much all orders. There's the section for diagnostics, there's a section for consults, and scheduling orders will always appear under communication orders. Okay. So moving towards the table of contents. So this is pretty much standard. We cannot make much changes to it. You cannot customize it. So this view would remain as is. So if you want to add an allergy for the patient, there is this section to add allergies. So what you would do is you would go and add, you would add in an allergy. Let's say you need to add a food allergy. Say food preservatives, you say okay. And then you can always add in a severity and add in other information. I just want to point out that all these fields that are in yellow are mandatory fields. So if I add a food, if the patient is allergic to food preservatives, it's going to ask me to select a category. So we'll say food and we'll say okay. So once we say okay, it's gonna give us the allergy that has been documented. So any clinician that would come in and go into the allergies tab, they're gonna see this allergy that was documented by the nurses. There's also a section for immunizations. So whatever immunizations that the patient has, you can always go in and add an immunization. So for example, when you select immunization, this is the view that you would have. So once you go into history and you say add to selections, you can add, so there's a list of vaccinations or immunizations that you can add for this patient. So let's just say COVID-19. And let's say add. Again, it's going to give me a few sections to document on, and yellow being mandatory. So I'm just going to document on these sections, and I'm going to say chart, and then it would have the immunizations documented for us. Okay. So for meds, there's a MAR window where you can see all the scheduled, unscheduled, PRN, and continuous infusion meds for that patient. And we do have filters to it. So if you want to see all active medications for the patient, you can select filters based on that, and it's going to give you a view of all those medications that have been ordered for the patient. Okay. We also have a functionality of SunQuest Clinical. So this is the functionality to collect lab orders. So I cannot demo this functionality at the moment because we're in build, but I can show you a snippet in the PowerPoint how that workflow would work. But other than that, whatever pieces that I demoed, any questions on that?
In terms of the MAR, so let's just say they get iron at home. Of course, they're doing it. We don't have to log whether they're doing it or not. But let's say they come in for a respite run and they just happen to need iron that day. Do I need to like order? Do I need to get an order for like a one-time iron order since we're giving it in facility?
Yeah, you can always place ad hoc orders based on the need for the patient. So so how you would do that is you can go under this section, you can go under add the same way we place med orders. So you can search in for a medication, let's say acetaminophen. So you select this med, you select the frequency or the order sentence, say okay. And then you can type in the physician's name. So this is a window that would pop up when you are placing an order. So can I just put in the test provider that we have? So we can say co-signature required, and this is a place where the co-signature required queue would pop into the message center that we were talking about earlier. So when we say okay, this acetaminophen order would come up, and then you can always place the order for the patient based on their need. And when you sign it, it's going to appear on the MAR for you to administer.
But I'm waiting for the doctor to sign it, right?
You can say no co-signature required, and you can just move on with the order. You don't have to wait for the clinician to sign it.
Oh, okay.
Just being mindful of time, so I'm going to quickly go back into my PowerPoint. Okay, so we talked about allergies, we talked about immunizations, MAR, nursing narrative note, results review. This is a better snippet of how MAR would look like, because it has the med orders for the future as well. So you can see all these orders that are being placed for that patient in a consolidated view. So this is the Clinical Connect application that I was talking about. So how that would work is usually you would get printers to print the Cerner labels, but the CST labels, and then you would have to turn on the printer and connect it with the Wi-Fi. You scan the patient's wristband, and then you open SunQuest, and then you would have to pair the printer, and then the lab orders would appear for that patient. So you just check that the lab orders that you're collecting the lab specimen for, and you just send it out to the lab. But training would be given on how to use the printers and how to use the Clinical Connect as we go into boot camps and stuff.
So it seems like we would have to print an armband for a patient coming for blood work.
You can, so you can print a armband, and you can scan the armband, and then the lab orders would appear on SunQuest Clinical.
And I'm wondering, I'm guessing HCS also already asked this, but what if a patient brings in their GP prescription, their GP lab rec to be done as well?
Yeah, so we do have that piece, and lab team is going to cover that piece of what happens if a patient brings in the lab orders and they do self-collection while they're being treated in the Nocturnal facility. So that's a whole different workflow, and we're going to go over that in our next session.
Okay.
So this is the HHD log that Vivi and Urban presented. So I'm going to skip over this. So that's the presentation that I had for the nurses for their workflow. Any more questions on that piece?
Not right now.
Okay. Vinny, are you back for the pharmacist piece? I know you were wanting for us to wait until you're back.
Sorry, Vinny, she had to drop.
Oh, she had to drop.
Yeah.
Do we have other pharmacists on the line?
Yes, it's Kevin. I'm the pharmacist at VGH.
Oh, hey, Kevin. So I'm just going to quickly, I know we just have 10 minutes left, and we can definitely revisit the workflow in our next session, but I'm going to quickly go into the pharmacist workflow and show you which sections you see when you open a patient's chart.
Okay.
Okay, so this is the landing page when a pharmacist would log into Cerner. This is their multi-patient task list. This would be their view. And then they would have all those patients that they're wanting to see. They can always customize this list based on this filter that we have. So this is change time frame criteria. So you can always go in and change the time frame, and based on those changes, your list would appear. Okay, so I'm just gonna quickly go into the patient. So this is how your landing page would look like when you first log into a patient's chart. So you can see here that you do have a pharmacy specific workflow. So this is an M page that has been personalized and customized for pharmacists. And you can see that you have different components to this M page. And this is a place where you can see the dialysis prescriptions. So whatever changes that the provider makes on the dialysis prescription, you can always see the updated prescription under this section. The next section is team communication. This is the same section. So exactly what I was trying to say earlier. So when I was logged in as a nurse, the nurse documented dressing change under team communication. So we're using the same patient now. So now when a pharmacist logs in, they can see what the nurse had documented under team communication. This is the HD log. So all this information, whatever information would be documented in iView would get pulled into the pharmacy workflow. So you have a consolidated section for all the information. So for allergies, we did document food preservatives. So you can see that those allergies pop up under this section. We do have pharmacist specific consultation notes. So if you wanna add a note for this patient, you can always go under this section. And you can type in a free text note. So I'm just gonna say XYZ. And then you can sign and submit. Pretty much the same workflow. The workflow is pretty much similar for all the clinic notes. And if you wanna, you can change the title of it. You can send it to a provider for their knowledge. And then once you sign it, once you sign that note, it would come under this documentation piece that we talked about earlier. So all the notes that have been documented on that patient chart gets placed under this section. Okay. You also have a tab for quick orders. So this is similar to what the providers have for their power plans. So if you want to place a medication order for the patient, you can go in and you can just select the medication. And you can select the order sentence. You say okay. And it would route to, once you place the order, you need to go into your little icon that's similar to a shopping cart. You can say modify details. And then you can place the order for ibuprofen for that patient. Just gonna say sign. So once you select this order, it would pop up, give you a pop-up window, and they can ask you for more information based on the medication order you want to place. And once you place that order, this medication would pop up under the medication sections. Okay. You also have the functionality of results review. This is pretty much a standard functionality for all professions. So for specific dialysis view, you can go under the dialysis view of flow sheet. And then you can see, you can also categorize it based on the levels. And if you say prescription, it's going to give you the prescription. If you say assessment, let's say if it has like iView stuff documented. So if you say pre-intra dialysis, it's going to give you a view of the pre-intra assessment of the patient. Okay. Yep. So this is pretty much the pharmacist view of the patient's chart. Any questions?
Oh, that looks good.
Okay. I know we're almost on time. Is there any social worker and OT still on the line? No? Okay. So I'll defer their topics to the next session because I know we're almost at time and it seems like they've already dropped off. So I'll quickly go back to the PowerPoint. So the remaining content that I had for today was for the social worker, for the occupational therapist. And for the next meeting, we can demo like patient list, how to customize a patient list based on the location or based on which resource they're creating their list for. So this content for the next session, I do want to point out that whatever you're manually documenting in Promise would remain in Promise. So you would have to do double documentation for, as Flo mentioned earlier as well, the transonic results, the dialysis status, the wait list. But the things that you do not need to document is the schedule. So we do have SIU and ADT interface. Cerner does have 2 interfaces with Promise. So that information would flow into Promise, being the caveat that you do select the Promise flag while registration. So that Promise flag is very substantial to be documented on. Okay, we can talk about FormFast, which forms go into Cerner, which forms cannot, which will remain on paper. And I do want to point out for the next session, we do have these topics. So first was the encounter strategy. How are we gonna best transfer patients from an HD to an HHD unit and back and forth? We did exclude the HH3 prescriptions design from this session because CST is still figuring out a better way to have that prescription in place. And once we figure out a way, and so that we can propose the best design for HH3 prescriptions. And also we would have BPMH and MedRec for the providers and pharmacists to be shown in the next session. The next topic that would be discussed is the lab rec that we were talking about. So we are still investigating what's the best way to put for that workflow, which a patient brings in their labs and they're either self-collecting or the nurse is helping them collect it, and how can we document those orders in Cerner. Okay. That's all I had for today. Any questions from anybody? No? Okay, I'll take the silence as a no, and we do have our next session scheduled on April 20th. So see you all then. Thank you.
Thanks, everyone.